Good afternoon, sir.
Good afternoon.
Shall we start, sir? It's 2 p.m. already.
Yes, you start.
Yes, sir. Good afternoon, everybody. I welcome you all to this KCIAPM slide seminar for the month of June. Today's slide seminar is being conducted by Father Muller Medical College, Bangalore, and along with them, jointly organizing this session will be Agilus Diagnostics, Bangalore. The first set, that is S1 to S3 and D1 to D3, will be conducted by Father Muller's, and the first half and second half will be taken over by Agilus Diagnostics. I welcome all the delegates to the session, and I'll be happy to announce that CapCon 2025 will be organized early next month from July 11th to 13th, and I hope to see most of you all there. And before wasting much time, I invite Dr. Umashankar T, Professor and Head of Father Muller Medical College, Mangaluru, to deliver the opening remarks before we start with the presentations of the postgraduates. Umashankar sir, welcome to the session.
Yeah. Can you hear me?
Yes, sir. Please go ahead.
Yeah. Thank you very much, Aditya, for handing over the stage to me. And greetings from Father Muller's Medical College, Mangalore. We are happy to conduct this month's online virtual fair seminar. And I would like to thank the organizers of KCIAPM giving the opportunity to host the session. Today we are hosting a session along with Agilus Diagnostics, Bangalore, and we are presenting total 6 cases. 6 of faculty will present each cases along with our other postgraduates also. And these all 6 cases were very interesting and they're handpicked. And this session will definitely help all the residents and practicing pathologists. Now I hand over the mic to Dr. Sualin, who is the academic coordinator of KCIAPM. Sue, please.
Dr. Sue, shall we get started?
Yes, good afternoon, everyone. We'll take the questions from each of the participants at the end. If any questions are there, please enter your questions into the chat box. The first case will be taken up by student's name is Dr. Hemant Subban, and the research faculty is Dr. Reshma Sunu, Professor, Department of Pathology.
Yes, ma'am. Good evening, everyone.
You must simply share your screen and start your presentation.
Yes, sir.
Remember to share the entire screen.
Yes, sir. I just started sharing, sir. Can you see it?
Yeah, open it up.
Yes. Shall we start, sir?
Yes, please go ahead.
Good evening, everyone. Today's slide allotted to me is S1. The history given is that it is a 52-year-old female, and it's a slide for diagnosis. So this, as you can see from the telescopic view, that it's a breast biopsy. It is covered by a stratified squamous epithelium with a basal pigmentation, suggesting that it is from the nipple areolar complex. Also, we can see that there are collecting ducts and terminal duct TDLU, terminal duct globular units present there, which shows bilayered epithelium with intact myoepithelial cells and basal lamina, suggesting that the epithelium appears to be normal. Also, we can see that there is a ill-defined tumor in the breast parenchyma. Here, we can see that there is a ill-defined tumor in the breast parenchyma. In a higher magnification, we can see that the tumor is composed of sheets of tumor cells along with the irregular anastomosing vascular channels within the stroma of the breast. The irregular anastomosing vessels are lined by single layer of endothelial cells, which appears to be plump, and surrounding stroma shows the dense lymphocytic infiltrates along with the tumor cells. Here in this slide, we can see that the tumor appears to be dissecting the adjacent fat along with the stromal fibrocollagenous stroma. We can see that there is both the solid component of the tumor involving the stroma, and also that appears to be a vascular component of the tumor. So the vascular component of the tumor is mainly composed of irregular vessels, which are lined by endothelial cells, which appears to be plump, and also showing atypia. As we can see in this slide here, that there is large nucleus with prominent nucleoli. Along with that, we can see that as the arrows indicate, there are a few areas of hobnailing. And in this subsequent image, we can see that there are a few mitotic figures ranging from 1 to 2 per high power field. We can also see that there is endothelial tufting, multilayering, and hobnailing can be seen at the places. And coming to the solid component of tumor, we can see that there are sheets of infiltrating tumor cells, which appears to be epithelioid in nature. They have a moderate amount of eosinophilic cytoplasm, along with a large round to oval nucleoli with a prominent macronucleoli. As we can see in this image also, we can see that there are 1 to 2 mitotic figures in hyperfield, along with the infiltrating tumor cells. Also, we can see that there is an extravasate RBC into the stroma. This is also an image which shows both the solid component of the tumor along with the vascular component of the tumor. We can see that there is a scattered lymphocytic infiltrates. Here in this lower image, we can see that there is a dense scattered lymphocytic infiltrates, and at focal areas it is also forming a lymphoid aggregates. And the background, we can see that there is a blood pool. There is a dense, vast extravasation of the RBCs along with the tumor. One characteristic feature of this tumor that we can see in this section is that vacuolated cells scattered among the tumor cells, which are intracytoplasmic vacuolations, either filled with the fluid, or we can see, as in the image, we can see that there are few erythrocytes present in the vacuole cell, which is suggestive of a new vessel formation. That is, the vasoformative nature of the tumor can be found in this section. So, on the peripheral of the lesion shows that there is a pool of blood along with the scattered few tumor cells. As you can see here, there is a few tumor cells scattered along with the pool of blood with a collagenous matrix. So, to summarize my case, it is a section study shows the breast tissue with the ill-defined tumor in the parenchyma composed of irregular anastomosing vessels dissecting the fibrocollagen stroma along with the infiltrating sheets of tumor cells. The vessel component, the vascular component, the vessels are lined by plump endothelial cells showing atypia with a large hyperchromatic nuclei and prominent micronucleoli, along with multilayering tufting and hobnailling. The mitotic, we can also see that there is occasional mitotic figures which is between 1 to 2 hyperfield. The stromal component of tumor is epithelioid in nature with the large cells and ill-defined cytoplasm and also prominent nucleoli. As we had seen that there is a dense lymphocytic infiltrates which is forming focal aggregates, along with the vasoformative nature, which is evidenced by the vacuolated cells filled with erythrocytes and platelets. My diagnosis for this case is that it is angiosarcoma with epithelioid variant, maybe in the intermediate this thing. Because the medullary IDC with the medullary also has dense lymphocytic infiltrates along with the sheets of tumor cells. There is a remote possibility that it could be IDC, which we can rule out by having a IHC done on CD31 and IRG and other vascular endothelial markers. These are my references for the case. Thank you.
Hello, good afternoon. Congratulations, Dr. Hemasudan and Shivoga Institute. It was an excellent representation of the case. I must congratulate you because you have not missed any findings. So first of all, I'll just take you through some of the case details so it becomes clear. Yeah. So this was a case of a 52-year-old female who presented with discoloration of skin of the left breast since few weeks, which was rapidly increasing in size. And on examination, she had a vague nodularity in the breast on palpation also. So past history of carcinoma right breast was there, and this was in 2015. And she had undergone a modified radical mastectomy of the right breast, and she had undergone radiotherapy. The diagnosis at that time was infiltrating ductal carcinoma grade 2, and ER/PR and HER2 were positive, and K67 was around 8%. Okay? And she has a very strong family history of cancer. So this is a clinical picture of the left breast. So it is showing erythema and nodularity, and you can definitely appreciate the code orange or the orange peel appearance. So the biopsy was first done, and in the biopsy, what we saw was solid nodules of human cells, excellently described by Dr. Hemasudan. And these had the characteristic features of being round to oval with high NC ratio, vesicular chromatin, and prominent nucleoli. And stroma was dense, there was dense lymphocyte and inflammatory infiltrate. This tumor, and of course, there was a lot of mitosis. It looked particularly very high grade. It was negative for ER/PR, HER2/neu, and K67 was 70%. So a diagnosis on biopsy was invasive breast carcinoma high grade. So after that, we received the modified radical mastectomy, and we saw that the skin lesion was quite large. And on serial sizing, we saw a hemorrhagic tumor in the central quadrant with the largest dimension of 5.5 centimeters. All margins, including the skin, were clear. Skin margins. So we saw the infiltrating tumor just like it was described, and there was infiltration of both the terminal duct lobular units as well as the adipocyte of the breast parenchyma. So this is showing the infiltration. So here on the left side is the tumor cells, and on the right side you're seeing the adipocytic tissue of the breast. And if you look at the tumor arrangement of the tumor, it looks like almost like it has undergone autolysis, almost like the tumors have fallen into the cystic spaces. So this is another picture showing the tumor infiltrating into the adipose tissue. I will not go much into the description because he has described it so well, but what I would like to highlight is the presence of the vascular channels and the atypical endothelial cells lining these vascular channels, and the atypia is quite high grade. So this is another picture where vasoformative tumor is there, and these vasoformative, the vascular channels are lined by very high grade tumor. And this is the low grade appearance of the same tumor shown in the beginning of the description of the tumor. Uh, yeah. So what happens is, in your biopsy sample, why it is important to recognize this is that if you receive only this part in your biopsy sample, you do not get to see an infiltrative portion, and this looks very low grade. You may make a false negative diagnosis of a low grade vascular tumor. Okay, so you should know that, yes. So finally, I'll show you this tumor cells also had papillary configuration. So microscopy is as described, clear margins were there, single lymph node was sent to us, which was negative. IHC was positive was CD31 and negative for ER, PR, HER2/neu, and Ki67 was 70%. So a diagnosis of angiosarcoma breast was done. So staging for angiosarcoma of the breast particularly is clinically irrelevant, and grading is also irrelevant, but morphologically you can still classify them for your satisfaction into well, moderately, and poorly differentiated. So breast angiosarcoma can be of two types, primary or secondary. When it is primary, it is usually seen in younger individuals. When it is secondary, it can be secondary to the lymphedema or the radiation that happens in patients who have undergone mastectomy. So initially, I mean, a couple of decades ago, when patients used to undergo mastectomy with lymph node clearance, they used to develop lymphedema, and then the angiosarcoma used to come. But these days, because of breast conservation surgery, the patient undergoes radiation, and then within a decade or so, the patient develops angiosarcoma. So there are two types of breast angiosarcomas, and both these secondary angiosarcomas are positive for high level MYC amplification at 8q24. So this is a characteristic marker for secondary angiosarcomas not seen in primary angiosarcomas, but actually clinically it makes no difference whether it's primary or secondary because both of them are really poor prognosis. So primary angiosarcomas, if they happen, they tend to be lesions within the breast, okay, within the breast parenchyma, not involving the skin. So radiologically, they look frankly malignant. FNAC gives a very high rate of false negativity rate is there. So grossly, it will be as described. I showed you a picture of it. Microscopically, again, it will have a wide range of morphology ranging from low grade to high grade, and some of them can appear epithelioid, as in this case. And it can be confused with carcinomas, just like it was with us. Radiation associated angiosarcoma usually affects the dermis of the breast, not within the parenchyma, but it affects the skin, like in our case, and within the radiation field. So she had undergone radiation for MRM for the right breast, and now she has developed angiosarcoma in the left breast. It may occasionally develop inside the breast parenchyma, but this is rare. Incidence is also very, very less. The mean tumor size tends to be larger than that of primary, and the average time between radiation therapy and development of angiosarcoma is 6 years. So skin thickening due to angiosarcoma may be, this is very important for us, that the skin thickening due to angiosarcoma may be masked or misinterpreted as skin changes that occur after radiation therapy, both clinically and radiologically. So if a patient comes with any skin changes, it is likely that it will be attributed to radiation induced changes both clinically and radiologically. So the degree of clinical suspicion must be very high for them to do a biopsy and for us to recognize that it could be an angiosarcoma. So there is a diagnostic criteria for radiation associated angiosarcoma. This is there in the WHO. So essential criteria include previous irradiation. The duration should be more than 3 years, predominantly dermal or subcutaneous involvement, vasoformative growth pattern with at least focal cytological atypia, and desirable criteria is MYC overexpression by IHC or amplification by FISH. Of course, IHC with CD31 should also have been there. It is not there in the essential, but that is what I thought. Then the second type of secondary angiosarcoma of the breast is the lymphedema associated. It was initially reported by Stewart and Travis, and it's named after them as their syndrome. It develops on lymphadematous limbs and chest wall after mastectomy and lymph node dissection, lower incidence in recent times. The differential diagnosis, we have received a lot of differential diagnosis for the case that was there, and many of the people have diagnosed it correctly as angiosarcoma of the breast. Some of the people have completely missed the site. Okay, the history of slide for diagnosis is always given when we understand that you don't need the history to make the diagnosis. So the breast, the nipple areola complex, and the lactiferous sinuses and ducts and the terminal duct globular units were very obvious in the slide. That is why we didn't give the site. So you are supposed to recognize the site and then make the diagnosis. So one of the differential diagnosis, especially if the tumor is very well differentiated, is atypical vascular lesion or proliferation. This is actually an entity in the WHO. This happens also on the previous irradiated skin. So this is why it causes confusion with angiosarcoma. It is, but unlike angiosarcoma, where we repeatedly showed you infiltration within the breast parenchyma as well as within the adipose tissue, this lesion is circumscribed and wedge-shaped in outline. Typically does not go beyond the dermis, and the vascular channels will be having hobnailed endothelial cells. So this is actually a differential diagnosis because history will be exactly the same post-radiation, and also it occurs in the skin of the breast, but it lacks the MYC amplification. Some of the people say this is a precursor to angiocarcinoma, angiosarcoma of the breast. Other DDs, depending upon how well differentiated the angiosarcoma is, you can have a host of vascular tumors. And if it is epithelioid variant, you can also confuse it with high-grade carcinoma and melanoma. Prognosis is uniformly poor, and usual 5-year survival rate is around 10%. So key points that we learned from this case is that high-grade angiocarcinoma of the breast can mimic high-grade carcinomas. This is what happened to us, okay? Because the biopsy was limited, everything was looking epithelioid, and the patient already had a history of carcinoma of the breast on the opposite side. This is what confused us in the first case. In case of high-grade lesion of the breast, which is triple negative, with history of radiation or lymphadenema, include CD31 in the next panel of markers. So initially you may have diagnosed it as carcinoma, but if it turns out to be triple negative, make sure you add CD31 also to check for whether it is angiosarcoma. A limited biopsy lacking vasoformative growth pattern can lead to false negative diagnosis if the angiosarcoma is better differentiated. Okay, that's a totally confusing sentence. What it means is, if it is well differentiated, you may think it is benign, and if it is poorly differentiated, you may think of some other malignancy. History of exposure to radiation within last 10 years must raise suspicion of angiosarcoma anywhere in the body. Okay, anywhere, not just limited to the breast. Grade and stage of angiosarcoma are clinically irrelevant. Thank you very much. I hope I didn't take too much time. If any questions are there, we will be taking it at the end of the presentations. Yeah.
All right, the next case is case S2. This will be taken up by Dr. Yashasvi V from Vasavaneshwar Medical College and Hospital. The faculty is Dr. Chandni B. Bandari, Assistant Professor, Muller Medical College. Hello, Dr. Yashasvi, are you there?
Shall I start, ma'am?
Yes, please start.
Good afternoon. Myself, Dr. Yashasvi from Basveshwara Medical College and Hospital, Chitradurga. I am presenting S2 case. This is a case scenario of 72-year-old male with complaints of epistaxis for 3 days.
Yes,
There is similar history of epistaxis for 1 month.
your slide is not
Examination,
visible.
ma'am.
Please share your screen. Dr. Yashasvi, you have to share your entire screen, then open your PPT and put it in presenter view. Dr. Yashasvi, are you there? We'll take up the next case in the meantime, case S3. This will be presented by Dr. Pooja Lakshmi S. from MBJ Medical College and Research Hospital, Bangalore. Associate Professor, Department of Pathology, Padma Medical College. We'll start sharing this.
Can I start, ma'am?
Yes, yes, yes.
Good afternoon. Myself, Pooja Lakshmi, first year pathology postgraduate from MBJ Medical College. The case given to us was S3 with a history of fever since 7 days and complaints of joint pain since 3 days with generalized weakness and mouth ulcers. One slide was provided for us. With the following clinical history, our DDs were viral infections, which includes parvovirus B19, Epstein-Barr virus, and cytomegalovirus, parasitic infections like visceral leishmaniasis, autoimmune diseases like Behçet's disease, SLE, and rheumatoid arthritis, hematological disorders like acute leukemia, MDS, and aplastic conditions like pure red cell aplasia and aplastic anemia. So this is a scanner view showing the smear of bone marrow aspirate. By looking at the cellularity, we probably think that the patient is an adult with myeloid to erythroid ratio of 3:1. This is the differential count with blasts 3%, promyelocyte 4%, myelocyte 19%, metamyelocytes 20%, segmented neutrophils and band forms 26%, erythroblasts 20%, 5% of lymphocytes, 2% of plasma cells, and 1% eosinophils. Bone marrow findings, erythropoiesis was normal in number with presence of giant proerythroblasts showing intranuclear inclusion bodies and cytoplasmic plebs. So this image shows proerythroblasts with cytoplasmic plebs. This is a giant erythroblast having large size nucleus and scant basophilic cytoplasm with intranuclear inclusion bodies resembling lantern cells. This is a more magnified image of a proerythroblast showing intranuclear inclusion body and cytoplasmic plebs. Myelopoiesis is normal in number, morphology, and distribution with normal maturation. Lymphocytes and plasma cells are normal in number. Megakaryopoiesis is also normal in number and morphology. In this image, we were suspicious of some intracellular amastigoids, because of which one of our DD was leishmaniasis. But since we could not find more of such cells and LD bodies, we thought it could be a degenerated cell. Coming to our differentials, Epstein-Barr virus and cytomegalovirus presents with fever and mouth ulcers. It usually has generalized bone marrow suppression. Since in the given case, the marrow had preserved non-erythroid lineages with giant normoerythroblasts, we excluded these infections. Next, coming to autoimmune diseases like SLE, rheumatoid arthritis, and Behçet's disease, it will show multilineage dysplasia. And our case did not have dysplasia outside erythroid lineage, and presence of giant proerythroblasts, we excluded these autoimmune conditions. Next, coming to MDS, it usually occurs in older patients with dysplasia across multiple hematopoietic lineages. Again, in the above case, there was no multilineage dysplasia, and presence of giant proerythroblasts with inclusions is not a typical feature of MDS. Acute erythroid leukemia will also have more than 50% erythroid blasts with dysplasia and myeloblasts. But in the given bone marrow smear, the myeloid and megakaryocyte series were normal, and blasts were also within normal range, excluding this diagnosis. Visceral leishmaniasis can also present with fever and weakness, and also bone marrow shows macrophages with packed amastigoids, and also LD bodies with nucleus and kinetoplast. Since the smear didn't show any of these features, we excluded visceral leishmaniasis and came to a diagnosis of parvovirus. Non-erythroid lineages are preserved, excluding leukemias, MDS, and aplastic anemia. Overlapping features like arthritis and mouth ulcers can be present both in infections and connective tissue diseases. And bone marrow becomes the diagnostic key. Since the marrow, it shows giant proerythroblast with blebs and nuclear inclusions, we strongly suggest that it is a parvovirus B19 infection. PCR is required to confirm diagnosis. Thank you.
I presented Dr. Kruja. Okay, so let me take you to the case. We'll discuss the history first, and followed by the lab investigations as well as the microscopic pictures. So this was a 7-year-old female, complains of high-grade fever since 7 days, and joint pain which was insidious in onset, non-migratory, which was for a duration of 3 days, along with mouth ulcers for 3 days. So on examination, this child had mouth ulcers as well as right cervical lymphadenopathy, which is not very significant, about a single lymph node measuring about 0.5 into 0.5 centimeters. And on abdominal examination, mild hepatomegaly was observed with no splenomegaly. So on history, to summarize, fever, joint pain, mouth ulcers, as well as mild hepatomegaly. So the clinical diagnosis, what they were thinking was atypical Kawasaki and SLE. Then other diagnosis we'll discuss following through the slides. So coming to the hematological investigations, hemoglobin was reduced, total count, platelet count was reduced. Fibrinogen levels were also reduced. Just a second. Okay, so hemoglobin, total count as well as platelet count was reduced, fibrinogen levels were reduced, PT and APTT were increased, direct and indirect Coombs test was negative, that is done to rule out SLE. Serum ferritin, serum triglycerides were increased, AST, ALT and LDH were also increased, whereas the other bilirubin was normal, globulin and albumin was normal. And this was a peripheral smear. So what do you observe in this peripheral smear, Dr. Pooja, if you could say? Dr. Pooja,
Yes, ma'am.
what did you observe in this peripheral smear?
It's a normocytic normochromic picture.
Okay,
Reduced WBC count.
okay, good. And platelet?
Platelets, yes, ma'am. Thrombocytopenia.
So you're
Pancyte,
okay. So the
pancytopenia.
peripheral smear which showed pancytopenia. Now coming to move on to the bone marrow aspirate, the cellularity was adequate. Okay, it was normal cellular with normal hematopoiesis, and you can see the megakaryocytes are also normal. What you're observing in the loop, what is this? These cells, could you please describe them? These cells.
Hemophagocytic cell.
Okay, these are nothing but histiocytes with erythrophagocytosis. Here you can see engulfed platelets by the histiocytes. Another view. What is this picture?
Phagocytosis by macro. It is a lymphocyte with a histiocyte.
Okay. Fine. This is a higher view of the same. An oil emulsion. For this, this is this. What about this image?
It is a platelets engulfed by histiocytes. Ma'am.
Yeah. So it almost mimics your
Het-
hematopoiesis, isn't it? Okay. Let's move on. There's another area where you can see the platelets as well as the what is this?
Lymphocyte.
Okay. So again, you can see here the same. So this is the biopsy. What do you see in the biopsy? Are you seeing any macrophages?
Yes, ma'am.
You see?
Center.
Okay, this is nothing but the multinucleated cell, nothing but the megakaryocytes. Okay, I'm not able to point out, but there are no macrophages here. Okay.
Okay.
So, what is your impression now? Could you define your impression? Now, I've given you the pictures again. Of course, the is more defined now, as well as your lab parameters. So, typically, patient had fever, isn't it? And
joint pain and ulcers.
lab parameters, which are pointing towards what is your diagnosis now?
HLH, ma'am. Hemophagocytic lymphohistiocytosis.
Okay, okay, good. So, anything, what are the pointers towards it?
Pancytopenia. Macrophages are there with the engulfed WBCs, I mean platelets and WBCs.
Yeah, okay, then that's it. That's why you say.
Yeah, normocellular marrow.
Okay, there are other pointers. Okay, let's move on to the discussion. So in your case, it was parvovirus, which you said. I just got a picture on it, but here this shows the inclusions, and there will be always a red cell aplasia in parvovirus infection, which is not observed in this case. Okay, so this slide was just given to observe the hemophagocytosis and then go on to the discussion. So differential diagnosis you need to keep in mind. In case of sepsis, also you can see hemophagocytosis. In roside-orphan disease, emperipelosis, where you see a cell inside a normal cell, again, it can mimic erythrophagocytosis. Langhans cell histiocytosis, where you see a lot of prominent histiocytes, although they lack here in this case, they will lack grooves and they will not demonstrate erythrophagocytosis in case of Langhans cell histiocytosis. So this common mimicker is leishmaniasis, which many students have given this diagnosis, which platelets phagocytes by histiocytes. So this is a common mimicker. So this has to be ruled out by observing other histiocytes, and of course, a clinical diagnosis will help. Okay, but if you are getting only one slide, that is a bone marrow aspirate, you need to look for other histiocytes to see for the other engulfed hemopoietic cells. So coming on to the test, further on, moving on to this case, they also they were thinking of Kawasaki disease, so they just did troponin I and natriuretic peptide, and also they did Epstein-Barr virus. Okay, so it had about 2025 copies per ml. And also genetic testing was done. Basically, in a child, when you think of HLS, you have to rule out a primary HLS. So genetic testing was also done. And SLE was, since we think of SLE, they had done this IgM and IgG antibodies to rule out the SLE features. Okay. So this was a final diagnosis was an Epstein-Barr virus-induced hemophagocytic lymphohistiocytosis. So is this clear, Pooja? Okay, fine. Okay, now coming to the treatment and follow-up of this patient, patient received rituximab, which mainly depletes the Epstein-Barr virus infected cells and reduces the viral load. And also the patient received HLH protocol, that is intravenous immunoglobulins as well as steroids. And the patient was followed up. I think now she's receiving the 4th dose of this rituximab drug. And patient that Epstein-Barr virus copies have been reduced. Now, coming to a brief discussion on hemophagocytic lymphohistiocytosis, this is basically a reactive condition, and we observe, as you observe in this case, a lot of there's cytopenia and signs and symptoms of systemic inflammation related to macrophage activation. So the macrophages get activated and they release cytokines, which brings about the cytopenia. So mainly important two cells which play an important role here is the macrophages as well as the CD8 T cells. So they will be activated and they will proliferate mainly in the bone marrow, the liver and the spleen, and they will release the inflammatory cytokines. So coming to the classification, we have to be, it is divided into primary as well as secondary. So primary is again subclassified as familial HLH, and this is mainly genetic causes we have to rule out, or else it could be immune deficiency syndromes or Chidiac-Higashi syndrome. And secondary causes, most commonly it is infection, mostly it is Epstein-Barr virus or cytomegalovirus, or it could be anything. For example, it could be a protozoal infection or a bacterial infection. Mainly the T cell lymphomas and Hodgkin's lymphomas is associated with HLH. HLH is also known as macrophage activation syndrome, and secondary HLH can be seen in patients with immunosuppressive drugs or in drugs certain like phenobarbital. So this is how they classify into primary and secondary. So our case was a secondary HLS ABV associated. So Epstein-Barr virus, mainly it is a herpes virus, spreads by salivary contact. Latency of this virus is mainly in the B cells. The young cells are young children are usually asymptomatic, and symptomatic individuals are mainly observed. They have usually fever, lymphadenopathy, sore throat, and hepatitis. And small portions of these individuals can have HLH as observed in our case. So coming to the pathophysiology, basically they release certain cytokines, mainly tumor necrosis factor, interferons, interleukin-1, interleukin-12, and they cause hematopoietic cell death, causing bone marrow suppression, cytopenias. Also, there is inhibition of lipoprotein lipase inhibition, causing hypertriglyceridemia. And this plasminogen activator gets secreted, causing reduction in fibrinogen levels, and ferritin levels are increased mainly because of increased heme oxygenase or causing increased ferritin production. So EBV-induced HLH is mainly because of the B cell stimulation causing cytotoxic T cells to be activated, causing hypercytokinemia where there is macrophage activation. It also causes activation of T and NK cell stimulation, causing secretion of cytokines like interleukin-2, interferon alpha, and interleukin-6. Also, there is activation or stimulation of this LPM protein, that is membrane protein, causing interferon secretion and macrophage activation. So clinically, these individuals can present with fever, as observed in our case, hepatomegaly, splenomegaly, jaundice, generalized lymphadenopathy, cytopenia, rash, as well as neurological symptoms. So according to the diagnosis, we make a diagnosis based on this HLA, that is diagnostic criteria. This is updated 2024 criteria. It takes 7 criteria into consideration. Earlier, the 6th one, this is excluded. So the updated one has only 7 criteria, 5 of which should be observed. So in our case, the patient had fever, patient had cytopenia, hypertriglyceridemia or hyperfibrinogenemia, documented hemophagocytosis,
ferritin levels were also increased. So the highlighted blue ones were observed in our case. So at least 5 out of 7 should be present for the diagnosis of HLH. Peripheral smear findings, as observed in our case, a patient usually present with pancytopenia, and also it can give you a clue to the primary diagnosis for the primary conditions. For example, you may observe atypical lymphocytes in case of familial histiocytosis or in case of viral infections. Coming to the microscopic description, usually the hemophagocytosis can be observed either in the bone marrow or in the liver, spleen, or in the lymph node. So these are few images of the same. So you can see the bone marrow aspirate displaying the erythrophagocytosis, the liver biopsy where there is Cooper cell hyperplasia with prominent erythrophagocytosis. Again, the lymph node biopsy with histocytic proliferation with erythrophagocytosis. So usually when you do a Pearl stain, the iron-laden macrophages will be more highlighted with ingested erythroblasts. A refined biopsy, you can also do a IHC marker, that is CD68, to identify the macrophages more better. So treatment is suppressing the immune response using intravenous immunoglobulins as well as steroids. And rituximab can be given, especially if the patient is having EBV-induced changes. So lastly, to conclude, Epstein-Barr virus is a well-recognized trigger as observed in our case for secondary HLS, especially in children. Among the viral-associated forms of HLH, Epstein-Barr virus usually has a worse prognosis, so early diagnosis is essential. And the diagnostic criteria, kindly remember, there are 7 criteria, out of which 5 should be present for the diagnosis. And the absence of hemophagocytosis does not exclude the diagnosis of HLH, and rituximab can be used when HLH is associated with EBV. Thank you.
Thank you, ma'am. Next, we'll take on case S2, Dr. Yashasvi. The faculty will be Dr. Chandni P. Bandari, Assistant Professor, Department of Pathology, Father Muller Medical College.
Hello.
Yes, Yashashvi, can you share your screen?
Yes, ma'am. Ma'am, am I audible?
Please continue.
Good afternoon. Myself, Dr. Yashasvi, first year postgraduate from Department of Pathology, Basveshwara Medical College and Hospital. Today I'm presenting case, S2 case. So the case scenario is a 72-year-old male with complaints of epistaxis for 3 days. There was similar history of epistaxis for past 1 month. Examination revealed cervical lymphadenopathy. The CBC was done and HB is 11.7. Total count 4,360 and the differential count. Platelet count was 2.35 lakhs. The slide given was one pap smear and one MGG slide of FNAC. So this is the low power view of the highly cellular FNAC smears, which showing lymphoid cells which are scattered in singles and in sheets. There is a monomorphic population of the lymphoid cells.
Can you just, 1 second, can you just put it in presentation mode?
Yes.
Yeah. And continue, please.
Ma'am, can I continue?
Put it in the slideshow.
Yes, ma'am, it is in the slideshow.
Okay, okay, continue please.
So this is the monomorphic population. So this is a low power view of the high power view of the monomorphic population of predominantly medium to large size lymphoid cells, and there are sparse population of small lymphocytes here. Predominantly there are medium to large size lymphoid cells. Uh, and the cells have a vesicular chromatin, and there is very scant cytoplasm, and few cells have indented nuclear margin or nuclear grooving, as we can see here. Uh, some cells have nuclear grooving. Some occasional cells show prominent nucleoli. Uh, this is the low power view of the MGG stained slide, which are showing highly cellular smears. Uh, this is the hyperbar view of the MGG slide, showing a monomorphic population of lymphoid cells, which are again arranged in sheets and in singles, consisting predominantly of the centroblasts and centrocytes. Uh, we can see prominent nucleoli in the cells, predominantly medium-sized cells. To summarize, these are hypercellular smears showing monomorphic population of lymphoid cells, which are arranged in singles and sheets, consisting predominantly of medium to large sized cells with sparse population of small lymphocytes. These cells have very scant cytoplasm, vesicular chromatin, with few cells showing indented nuclear margin or nuclear grooving, and occasional cells show prominent nucleoli, and the background shows lymphoglandular bodies. So with this provisional diagnosis, my provisional diagnosis is non-Hodgkin's lymphoma, and the differential diagnosis is follicular lymphoma. Because there are few cells, predominantly the cells are of medium-sized cells, lymphoid cells with few small cells with scant cytoplasm, and there is cleaved nuclei and prominent nucleoli. Uh, and the possible reasons for the epistaxis in this case could be lymphoma involving the nasal cavity or nasopharynx, and it can be coagulopathy associated with non-Hodgkin's lymphoma. Since the given platelet count of the patient is normal, the bleeding due to thrombocytopenia can be ruled out. And the investigations, we have to do the coagulation profile, nasal endoscopy, and biopsy. And to confirm it as non-Hodgkin's lymphoma, the IHC markers such as CD45, leukocyte common antigen, can be done. It is positive in almost all non-Hodgkin lymphoma. And CD43, which is positive in many B and T cell lymphomas, CD3, CD10, and CD20 markers. Thank you.
Very nicely presented, Yashashvi. Uh, so you did get the answers right. Maybe one of the part we can still refine. We'll have a better look at it with a better history. Can you please stop sharing so that
Yes, ma'am.
yeah. Okay. So to summarize, this was a 72-year-old male patient with epistaxis and cervical lymphadenopathy. So there are two things here to look at in the history. CPC was overall normal. There was just mild anemia. And as rightly Yashashvi told, that there was monomorphic population of small to medium-sized cells, irregular nuclear contours. So I would be very happy with the diagnosis of non-Hodgkin lymphoma on a FNEC slide, which could be one of these differential diagnoses. It could be SLL, follicular, marginal zone, mantle cell lymphoma. Okay, so the pictures you have already discussed. This was a lymph node core biopsy, which was also sent. And here you can see that there are few the cells have this angulation, the angular margin is seen. Okay? In addition to this monotonous or monomorphic population of the small to medium lymphoid cells. This patient, the report was given as non-Hodgkin lymphoma in the FNAC. Peripheral smear was done, which was normal, only mild anemia was there. This patient also had a bone marrow aspirate for staging, did not show any lymphoma infiltration. Bone marrow biopsy, also no infiltration. Cellularity was normal and all other lineages were there, well preserved.
This was the IHC done on the lymph node biopsy. So Yashashvi, can you just have a look at this and tell me what would be the possible diagnosis with this kind of IHC profile?
Ma'am, I'm unable to see the slide.
You are unable to see? Okay. Anyone else can answer in the chat box? Okay. It is fine. Then I will continue. This is CD20 positive, CD3 negative, CD5 focal positive. Okay. Mantle, correct. Okay, cyclin D1 is positive, SOX11 positive, CD10 negative, and Ki67 was 12 to 15%. With this, the diagnosis is mantle cell lymphoma. Anyone with the genetic translocation in the chat box? Yes, it is B lineage, as written in the chat box. Translocation? Yashashvi, do you know? Okay, it is 1114 translocation. Okay. Now coming to the second part of it, which is the epistaxis in this case. So despite of normal platelet count, bleeding due to acquired causes need to be thought of. We can have Glanzmann's thrombasthenia or even von Willebrand disease in that case. Here, Glanzmann thrombasthenia, there was a qualitative defect of the platelet function due to autoantibodies against the GP2B3A complex, because of which the platelets fail to aggregate despite of normal numbers, and acquired Glanzmann's thrombasthenia can be associated with lymphoproliferative disorders, including NHLs. So this was the platelet function test of this patient, in which ADP was 27%, epinephrine in the test was 10%, arachidonic acid was 3%, and ristocetin was 78%. This platelet function test was done by light transmission aggregometry. So here you see that ADP, epinephrine, and arachidonic acid has reduced aggregation, whereas ristocetin has normal aggregation. This kind of pattern can be seen in Glanzmann thrombasthenia. Okay, so this is a graph from another, just for depiction sake I have taken. So you can see all the first three lines which are flat, whereas the aggregation is seen only with ristocetin. Okay, so this case had two portions. One was first to identify that it is NHL, and the second, which was more challenging, which was the epistaxis part. How do we explain epistaxis in this case? So the first, to discuss the approach to NHL, as nicely told by Yashashvi, you have to look at the cellularity, the cell size. Here it was small to medium, and some of you have given as DLBCL as an answer for this particular case, but these cells were majorly composed of small to medium sized lymphoid cells. Okay, nuclear features. Here we can see that cleaving, although we classically see it in follicular lymphoma, it is not very specific for it. It can be seen with irregular nuclear membrane even in mantle cell lymphoma. Okay, background lymphoglandular bodies need to be seen, and ancillary test needs to be done on a biopsy. Now, in this case, we had a core biopsy, but the best would be an excision biopsy, which would tell us the architecture, composition of cells, the cell morphology, and the background. Okay, so we do an IHC panel to differentiate various lymphoproliferative disorders. Coming to the second part, why suspect platelet function disorders in this particular case? First of all, there was normal platelet count, and here to bring about another thing, that is the prothrombin time and the activated partial thromboplastin time, along with fibrinogen levels, all of them were normal. Okay, so the platelet count was normal, the coagulation profile was normal. It was a short duration of presentation with mucocutaneous bleeding, that is epistaxis, and later on we found out that lymphoma was an underlying cause for this. The test to be done is aggregometry, which can be light transmission aggregometry, and we have other things which can be done as well, like flow cytometry, which uses CD41 and CD61, which will be reduced or absent in case of Glanzmann's thrombasthenia. Also, von Willebrand disease can present with your acquired causes of bleeding in such cases. The relevance here is this identification that it is a qualitative defect rather than the thrombocytopenia or any other local causes is to guide hemostatic management before biopsy or surgery, and it indicates autoimmune platelet dysfunction secondary to lymphoma. So, take home message in this particular case is that cytomorphologic features will help you diagnose a non-Hodgkin lymphoma on FNAC slide. Immunophenotyping is essential to distinguish it from the various types of NHLs. Bleeding in hematological malignancies is not always thrombocytopenia. And in this particular case, we had mantle cell lymphoma with acquired Glanzmann's thrombasthenia. Is quite rare, but it is an entity which should be known and remembered. All the best, and we'll move on to the next case after this.
The next case is case D1. This will be taken up by Dr. Malvika G from Kempegowda Institute of Medical Sciences, Bangalore. The faculty is Dr. Prashant Rao, Assistant Professor, Department of Pathology, Father Muller Medical College.
Hello. Malika?
Good afternoon, sir.
Yeah, you can share your presentation and start the presentation.
Sir, is my presentation visible?
Yes, continue.
Good afternoon. I'm Dr. Malvika, final year postgraduate student from Kempegowda Institute of Medical Sciences, Bangalore. The case that was allotted to us is C1, the history being a 35-year-old male with left eye lateral orbital mass gradually progressing in size for 2 years. So this was the scanner view. What we saw was that there predominantly is a well encapsulated neoplasm, also surrounded by the adjacent relatively normal looking structure. So this is a closer view of the morphology. What we're seeing on the right hand side is the structure of the lacrimal gland, which is composed of predominantly serous acini with few ducts, and these acini are mainly arranged in lobules separated by the fibrous septae. But what is striking is that there is a thick fibrous encapsulation, and beside which we are seeing a definite tumor. So this, I would like to highlight the thick encapsulation of the tumor. And what we're seeing in the within the tumor mass is basically like a mixture of components or biphasic components. So here what we're seeing is predominantly the epithelial differentiation with the cells being arranged typically in the ductular pattern. And also what we're seeing is that some of these show dilated spaces with intraluminal secretions within them. So this is a higher magnification of the predominantly epithelial component which are arranged in ductular pattern. Also, the other component that was striking was basically the stromal elements, which in this case was in the form of these numerous bluish areas, which have this chondroid to myxoid appearance, and also, as I'd already mentioned, the intraluminal secretions within them. So as I was mentioning about the largely bluish looking areas, which were basically the chondromyxoid areas, which were widely scattered within the tumor mass, and also with the presence of some of these tripolar or the stellate cells, which was embedded within this matrix. So this is a higher magnification, a view of the chondromyxoid matrix. So in this image, we can definitely see the biphasic pattern or the mixed modality of the tumor mass. On the left-hand side, we see predominantly the epithelial cells, which are arranged in ductular pattern. And on the right-hand side, we're seeing the predominantly bluish looking area, which is nothing but the chondromyxoid area with abundant stellate cells in the middle. Also, what we saw was the focal areas of hyalinization, which was represented by these pale eosinophilic areas with focal lymphoplasmacytic cell infiltrate as well. So to summarize my case, what we saw was a well-encapsulated neoplasm and basically composed of biphasic components, that is the epithelial and the stromal component. The epithelial component predominantly arranged in ductular pattern, And the stromal component is mainly composed of the chondromyxoid matrix and also focal areas of hyalinization. And what we saw was focal lymphocytic infiltration. Also, there were no areas of atypia that was observed in the sections study. So with this, my diagnosis would be pleomorphic adenoma from the left orbital mass arising from the lacrimal gland. Thank you.
Yeah, thank you. You can stop sharing your screen. Right. Um, so as we have the case, it's a 35-year-old male with left eye lateral orbital mass, which is a gradually progressing one in size for 2 years. Yes, and diagnosis is pleomorphic adenoma of lacrimal gland. Excellent, Dr. Malika. So you've got the diagnosis right, and also the most important point of getting this case is to identify the native structure, that is lacrimal. Okay, right. The other responses that we have got, most of them have um, most of the diagnoses have been correct, that they have identified that it is of lacrimal gland, and there are few who have responded as chondroid syringoma. That is basically the same tumor, but it is associated with the skin. It's a dermatological counterpart. Right. So other varied responses like retinoblastoma, myoepithelioma, hemangiopericytoma, it's basically, this case is basically not a malignant tumor. Right. So ophthalmic examination of this particular case, it was a non-tender swelling and extraocular muscles were normal on examination. Exophthalmometry of both eyes were normal. That means there was not much of proptosis in this particular case, and the fundus was also normal. So there was no visual disturbance. And gross examination was that it was a pale white to pale yellow, well circumscribed nodular tissue that was received. And as you have already described all the microscopic findings, I'll not be discussing it much. But as we can see in the bird view, it is an encapsulated and well circumscribed tumor. And the native tissue has to be identified, that which you have correctly mentioned, the composition of it, that it is lacrimal gland with acini ducts, and the lesion being a mixed, benign mixed tumor, right? Okay, the benign mixed tumor, which is composed of epithelial, myoepithelial, and the chondromyxoid elements, right? So these chondromyxoid elements are basically the association of myoepithelium, rather than a true mesenchyme, right? About the gland, lacrimal gland, it is in the eye socket, right? It is upper and outer, right? In the location, right? Fine. So there is, right, just a second. Fine. So in this case, this lacrimal gland was involved, and identifying this as pleomorphic adenoma is right, because this pleomorphic adenoma is the most common epithelial tumor of the lacrimal gland. And as in this case, the presentation has been a slow growing one, painless, right? And the clinical diagnosis was initially, clinically, it was thought of as a dermoid cyst or a lacrimal cyst, right? Because it was intraorbital. So 5% of all intraorbital masses originate from lacrimal gland. So any intraorbital mass presentation, 5% can be originating from this particular gland. And majority of lacrimal fossa lesions basically are inflammatory lesions. So epithelial tumors account for about 30% of these lacrimal gland lesions, right? Now, I'm not going to discuss much of this. So looking at all the tumors of the lacrimal gland, we have benign and malignant. And among the epithelial tumors, pleomorphic adenoma is the commonest, followed by others like oncocytoma, myoepithelioma, and such. Right? And we also have lymphoid tumors to consider, mesenchymal tumors to consider, and secondary carcinomas also to consider in the clinical differentials. Right. So among the lacrimal gland, talking about the lacrimal gland, there is an orbital lobe and a palpebral lobe to it, and about 84 to 90% of this pleomorphic adenoma occurs in the orbital lobe, and only the remaining few percent, 10 or plus percent, occur in the palpebral lobe. Right. So the common presenting symptoms are the fullness in the temporal upper eyelid, which it was a presentation in this particular case. There can be proptosis, diplopia, visual impairment, and displacement of the eyeball, typically downward and nasally due to the presence of the tumor location near the lacrimal fossa. That's the reason I showed the picture of the anatomy of lacrimal gland. So average age of occurrence is 40 years, which was similar to our case, and the duration is usually 2 years, right? If the duration of presentation is less than 10 months, you will have to think of a malignant or a malignant tumor rather than a benign one, right? So clinically, other differential diagnosis to consider are hemangiomas, dermoids, and others, right? So this pleomorphic adenoma, as you have rightly mentioned, it's a benign mixed tumor, which is a mixture of epithelial and myoepithelial elements with a characteristics matrix-rich stroma produced by the myoepithelial cells. And this is a pleomorphic adenoma as is seen commonly in salivary gland, right? So is there any similarity? Yes, all the pleomorphic adenomas that occur in salivary gland, this case in the lacrimal gland, as well as those occurring in the skin, that's chondroid syndrome, all share similar genetic signature of PLAG1 gene translocation, right? And you will have to think of carcinoma ex pleomorphic adenoma as a malignant counterpart. Yes, thank you. All the best.
Thank you, sir.
Next case is case B2. This will be presented by Dr. Rajshri Chowdhury from
Yes, ma'am.
Bangalore. You can start your presentation. The faculty will be Dr. Christina Gomez, Assistant Professor, Department of Pathology, Father Muller Medical College.
Yeah, you can start, Raj.
Yes, ma'am.
Keep it in.
Good afternoon. I, Dr. Rashri Chaudhary, from Department of Pathology, Raja Rajeshwari Medical College, Bangalore. Case allotted to us was case number D2. Case detail given to us was slide for diagnosis. So this is the section of the appendix on the whole mount view.
Put it in slideshow.
Slideshow.
Dr. Rajeshri, I think you need to share the entire screen. You not share the entire screen. Stop sharing and click on entire screen.
Yes.
Click on share screen and select entire screen. Tap on the screen before clicking on the share button. Please click on the slideshow.
Yes, sir.
Go ahead.
Yes, sir. So this is this section of the appendix on the whole mount view. Next image, this shows the section of appendix with mucosa, submucosa, muscularis propria, and serosa. This image shows the reactive lymphoid follicles with dense lymphocytic infiltrate in high power. This image shows the section of appendix showing well circumscribed tumor on the scanner view. This image shows the closely packed nest of the tumor cells in 4x. Here, there are the two images in low power view. Left side image show the tumor cells which are arranged in nest pattern. Right side image show the tumor cells which are arranged in trabecular pattern. This is the same image but in high power view. This shows the tumor cells which are arranged in a uniform population of cells with the round nuclei, and they are finely stippled chromatin with the moderate amphiphilic granular cytoplasm. So with all these findings, my summary, we were given the section of appendix with well circumscribed tumor. Cells were arranged in nest and trabecular pattern. With there were uniform populations of the cells with round nuclei and finely stippled chromatin, which was salt and pepper chromatin. There were abundant amphiphilic cytoplasm. No necrosis were noted. So by all these findings, my diagnosis is a well differentiated neuroendocrine tumor of appendix. I will discuss little about neuroendocrine tumor. So well differentiated neuroendocrine tumors are the most common type of appendiceal tumor. They are identified in less than 1% of appendectomy specimens and are more common among adults than the children, but they can present at any age. They are the incidental findings and can be associated with acute appendicitis as a result of the obstruction of the lumen. In terms of location within the appendix, these can occur at the tip or the distal third of the organ. Grossly, these tumors are firm, grayish white, and fairly well circumscribed but not encapsulated. They acquire a characteristic yellow color after the formalin fixation. These tumors are composed of tightly packed solid nest of small monotonous cells with occasional acini. These tumor cells contain abundant amphiphilic, often granular cytoplasm. These nuclei are typically round with coarse salt and pepper chromatin, and there are small nucleoli and mitotic figures are rare. Enterochromaffin cells, they are strongly immunoreactive with chromogranin A and synaptophysin, and most enterochromaffin cell tumors shows a very low Ki67 proliferative index. So this is the classification and grading criteria for neuroendocrine neoplasms for the GI tract. So neuroendocrine tumors are classified as grade 1, grade 2, grade 3. They are well differentiated tumors. So grade 1 is of G1 is of low grade tumor with mitotic count of less than 2 and Ki67 index is less than 3%. In intermediate, they have mitotic count of 2 to 20 with Ki67 index 3 to 20%. In high grade, they have a mitotic count of more than 20 and Ki67 index also more than 20%. Then neuroendocrine cell carcinoma is classified as small cell type and large cell type. They are poorly differentiated and they are of high grade with mitotic count and mitotic count is more than 20 and Ki67 index is more than 20%. Then next is the mixed neuroendocrine neoplasm. They are well or poorly differentiated. They are of variable grade, mitotic count and Ki67 index. Thank you.
Yeah, excellent presentation, Dr. Rajri. You have covered almost everything. I think
Thank
there's
you,
one
ma'am.
point to tell. You should have written something about mitotic figures, the histopath description. So
Yes,
there
ma'am.
was no mention of mitotic figures. Other than that, you have covered everything. Let's just show the IHC pictures.
Yes.
Dr. Rajeshri, can you stop sharing your screen?
Yes, ma'am. Stop. Stop.
Okay, so this was the synaptophysin which was done, synaptophysin and chromogram. It is taken in the cytoplasm. So why it is taken in the cytoplasm? Because only granules are present in the cytoplasm. So that you have to remember. Every time people get confused whether it is cytoplasm or nuclear. And then this is the Ki67. You can see here the Ki67 is definitely low. It is less than 2. So it is a neuroendocrine tumor, grade 1. Rest of the points you have covered everything.
Yes, ma'am.
All right, next case will be taken up by Dr. Pragya.
Good afternoon, ma'am.
Good afternoon. You can start presenting.
Yes. Good afternoon, everyone. Myself, Dr. Pragya Jaiswal, second year postgraduate from BLE Shri B.M. Patil Medical College, Hospital and Research Center, Vijaypura, and I'll be presenting case D3 for today's slide seminar discussion. The case scenario given was of a 52-year-old female on oral therapy for anemia, presents with epigastric discomfort. One slide was provided for evaluation, comprising of two serial sections and having three tissue bits. So at LOPA, we observe the gastric mucosa, which is comprising of the lining epithelium, lamina propria, and the muscularis mucosae. These are the mucosal glands, and overlying is the mucin along with RBCs. The glands appear to be elongated and tortuous and are lined by columnar epithelial cells, comprising of the parietal cells and the chief cells. A notable finding is the presence of brown-black crystalline pigments, which is seen at the surface of the mucosa. These are the high power views, the 4x and 10x, and we can appreciate these crystalline pigments on the surface of the mucosa. Lamina propria shows coarse brown-black pigments which were distributed in patchy pattern. Also, these pigments were deposited in the foveolar epithelium, indicating an epithelial uptake. So the overall glandular architecture is preserved, and in foci, foveolar hyperplasia is noted. Scattered eosinophils and lymphocytes were seen in the lamina propria. This was another tissue bit showing gastric mucosa and the presence of the crystalline pigments, which were brown to blackish in color, and the surface of the mucosa is present. So to summarize, the section was of the gastric biopsy, which showed all the three layers, and the mucosa showed preserved glandular architecture. The striking feature was the presence of coarse brown-black pigments, which was distributed in a patchy pattern within the lamina propria, along with the scattered eosinophils and lymphocytes. At foci, pigment was also noted within the gastric foveolar epithelium, and there was no evidence of dysplasia or malignancy. So, coming to the diagnosis, features are suggestive of iron pill gastritis, a type of mucosal gastric siderosis secondary to oral iron therapy. And Pearl's Prussian blue stain is advised for the confirmation of iron pigment. So, the points favoring to my diagnosis was that the patient was on oral therapy for anemia, and there was this scattered granular pigment within the lamina propria and extracellularly. There were associated epithelial changes along with inflammation. So basically, the histological patterns of gastric mucosal cirrhosis, it shows three patterns. So this completely fits in the pattern 2, as the patient was on oral iron medications. There were brown crystalline materials which were present in lamina propria along with inflammation, and they also extracellularly. Thank you.
Very good presentation, Dr. Pragya.
Thank you, ma'am.
So it was a pretty much straightforward case. There's not much left for me to say. So, as you said, it was a 52-year-old female, complaints of epigastric discomfort. The endoscopy findings were a patchy erythema and edema, non-specific findings. You saw the crystalline black-brown pigments that were present only on the surface. They were not within the glandular glands or the glandular epithelium, actually. This is the Prussian blue stain. So, this confirmed that this was actually iron. All right. So the
Yes.
diagnosis, as rightly said, was iron pill gastritis. It's a form of chemical gastritis that causes direct mucosal injury. It's especially because of your oral iron tablets, which are ferrous sulfate. These pills can oxidize in your acidic environment of the stomach, leading to the generation of free radicals that lead to local corrosive injury. So you'll have superficial mucosal necrosis, iron deposition in the gastric mucosa. Now, how do you differentiate this from your systemic iron hemochromatosis? In your systemic iron hemochromatosis, you'll actually see them within the glands and the glandular epithelium. All right, the common risk factors is your high dose or prolonged oral iron therapy, elderly patients, esophageal or gastric motility disorders, and inadequate dilution. That is when they don't take food or water with their tablets. Histopathological features we've already gone through. You can also see some mild to moderate chronic gastritis. Most of the times the biopsies will be sent with a differential diagnosis of H. pylori. In H. pylori, you'll also get intestinal metaplasia. Over here, you won't get that. All right, so the clinical evidence is that it's under-recognized cause of upper GI symptoms in patients on oral iron therapy. It can mimic gastritis from NACIDs or your H. pylori infection. Diagnosis, as usual, will be confirmed with histopathology. Symptoms will improve upon discontinuation or switching to liquid iron formulations. Your differentials can be your chemical reactive gastropathy, H. pylori associated gastritis, or your systemic iron overload. Another pigment that can also resemble this is your melanosis. Anyways, thank you. Since we're short of time, we'll continue with the cases of Agilus Diagnostics. Dr. Sunit.
Hello. Hello. Am I audible?
Yes, ma'am.
Good afternoon, everyone. My name is Dr. Sunit Kaur. I am the lab director for Agilus Diagnostics, Bangalore. It's a great privilege and it's a great academic feast. We are really enjoying it. Now, I would request one of my clinical seniors histopathologists, Dr. Ansa. She will be presenting her case. Dr. Ansa, can you please join?
I will first call upon the postgraduate, Dr. Mehraj, to please show her case and discuss it first. Dr. Mehraj, the stage is yours.
Am I audible to you?
Yes, please continue. Can you please share your screen?
Yes, ma'am. I'm doing it, ma'am.
Okay.
Ma'am, is it visible to you?
Yes, please continue.
Good afternoon, everyone. This is Dr. Mehraj Parveen, second year postgraduate from ESIC MCPG IMSR, Rajajinagar, Bengaluru. So the case history that was given to us was a 39-year-old male with a lesion over dorsum of hand, query pyogenic granuloma. So we received a single slide. Under 0.25x magnification, it was seen that the section shows 5 fragments of skin biopsy. Under 4x magnification, we observed that the epidermis was showing ulceration and parakeratosis. Under 2x magnification, the epidermis showed pseudoepitheliomatous hyperplasia. This is the higher magnification. Under 4x, the pseudoepitheliomatous hyperplasia was seen. And under 10x magnification, we observed that the epidermis showed neutrophilic abscesses. This is one more image showing intraepidermal neutrophilic abscess. So under 20x magnification, thick-walled sclerotic or copper penny bodies or medlar bodies were seen. This is the similar image showing thick-walled copper penny bodies under 20x magnification. Also, the papillary dermis showed medlar bodies with mixed inflammatory infiltrate and giant cells. The 20x magnification of the dermis also showed mixed inflammatory infiltrate with a few congested and dilated blood vessels. Under 40x magnification, the dermis showed mixed inflammatory infiltrate sclerotic bodies within the giant cells. In this image, we can observe that the giant cell contained the sclerotic bodies. This is one more clearer image of 40x magnification showing the copper penny bodies or the medullary bodies. So the microscopy proper, we received a digitally scanned slide showing 5 sections of lesional skin tissue showing epidermis, dermis and the subcutis. The epidermis showed focal ulceration while the surrounding epithelium showed pseudoepitheliomatous hyperplasia, parakeratosis, intraepithelial neutrophilic microabscesses, and the papillary dermis showed pigmented fungal elements which are reminiscent of these copper pennies or the medullary bodies, characteristically which are seen in chromoblastomycosis. Also noted was the dense mixed inflammatory infiltrate in the dermis, which was comprising of neutrophils, few eosinophils, lymphocytes, plasma cells, and the foreign body type of giant cells. Some of these giant cells also showed intracytoplasmic medullary bodies. The sections from the subcutis were unremarkable. So to summarize, the lesional skin tissue showed epidermal ulceration, pseudoepitheliomatous hyperplasia, neutrophilic microabscesses. The papillary and the deep dermis showed mixed inflammatory infiltrate with pigmented fungal elements, which are copper pennies or medullary bodies, with a foreign body giant cell reaction, and the subcutis was unremarkable. So the diagnosis being chromoblastomycosis, dorsum of the hand. Coming to differential diagnosis, pheohyphomycosis. In this, we see pigmented septate fungal hyphae, not the muriform bodies or the sclerotic bodies. These will be filamentous and yeast-like forms. Differentiating points are no medullary bodies. Fungi appear as hyphae, often branching, irregularly pigmented. Then other DDs which could be given are blastomycosis. They have thick-walled, broad-based budding yeast forms with the pseudoepitheliomatous hyperplasia. The differentiating points are the fungal forms will usually be larger, non-pigmented, with broad-based budding. Then histoplasmosis. Uh, this will contain small intracellular yeast forms within the macrophages and granulomatous inflammation. There will be no pigment, no pseudoepitheliomatous hyperplasia, and no medullary bodies. Then the striking feature what we see in chromoblastomycosis will be the pseudoepitheliomatous hyperplasia, which will initially confuse us with the squamous cell carcinoma, but there will be no keratin pearls, no cellular atypia, and invasion. So this led to the diagnosis of chromoblastomycosis. Thank you. These are my references.
Very well done, Dr. Mehraj. You have done a very good presentation. I believe that she has actually covered all the salient features of the case. I just have to add on some more points. I will just share my screen right now. Hello, is the screen being seen?
No answer. It's not visible.
Ma'am, is it being visible now?
Answer, it's visible.
All right. So good afternoon, everyone. My name is Dr. Ansa, and I'm a consultant histopathologist working in Agilus Diagnostics, based in Bangalore. So Dr. Mehraj has actually covered quite a lot of features in her PPT, but I'll just add on to it. Now, this is actually a 39-year-old male who had a lump on the bottom of the hand. And there was actually a clinical suspicion of only a pyogenic granuloma. The clinician was not suspecting any fungal infection for that matter. Now, when you saw the sections, actually, if you see the upper left picture, you're seeing something known as a pseudoepitheliomatous hyperplasia, which is nothing but the proliferation of the retroregis well into the dermis that can be seen secondary to any infectious causes, inflammatory causes, or even any malignancy present in the dermis. The upper right image is showing a microapses, which are basically aggregates of neutrophils, and you can actually see these small brown, round to oval or spherical structures, which are surrounded by these dense neutrophilic infiltrate with karyotactic debris. The same feature was also seen in the dermis, that is in the lower left picture. You're seeing the organism within the giant cells, and these organisms or these structures are seen either singly or in clusters. Now, these are more pictures of the organism which we saw in the dermis. They're all seen either in clusters or singly scattered. The second picture is actually showing the sperules or oval structures of the spores, and you can see some hyphal forms as well here. And the third picture is showing a giant cell. Okay. I'm sorry, there was a distraction. Now, we hadn't shared these two pictures before. This is the GMS and the PAS stain. You can see the red arrows highlighting the spherical organisms as black circular outlines. And in the PAS stain, you're seeing the same light pink outline of the spores and the hyphal forms in the picture above. Now, there's no other diagnosis apart from a chromoblastomycosis made with this case, like Dr. Mehraj said. And when we went to the tabular column of all the diagnoses given by the postgraduates, almost all have given the right diagnosis. The main purpose of giving such a case was not only for the diagnosis, but also to discuss the various differential diagnoses that should come into mind should a case like this be presented to you. So now this just a brief review about chromoblastomycosis. Now this is basically a dimorphic fungi. Dimorphic fungi meaning it has got a yeast form as well as a hyphal form, and classically they present with these verrucous lesions on the skin at the site of inoculation. So it can either be on the feet if the patient has incurred the organism by walking barefoot, or on the hands. Now this is how the spores and the hyphae look of the organisms, and this is how the subarachs agar look when the organism grow in colonies. Now, one of the classic feature of this organism on a KOH mount is actually the presence of these copper bodies or the medullary bodies, which are actually these brown pigmented round to oval structures with a transverse septate or a line in between their body that resembles the copper pennies. Now, the name medullary bodies came into existence because of the fact that they resemble a fruit-like structure that is called medulla that belongs to a rose family. Now, whenever you have a constellation of findings like pseudoepitheliomatous hyperplasia, presence of microabscesses in the epidermis or the dermis with a giant cell response, with or without granulomas or even plasma cells, dermal fibrosis and increased capillaries, a high degree of suspicion should be there regarding an infectious etiology. So this is the same thing that we had in mind. And there's a wide plethora of differential that can be considered, mainly infectious, but also non-infectious causes like squamous cell carcinomas and melanomas. Now, I'll just briefly describe each one in detail. Now, the common differentials for fungal organisms which can be confused with chromoblastomycosis include: one is sporotrichosis, which is also favorably known as a gardener's or a rose breeder's disease, which is typically seen in people who grow plants like roses at home. Now, this is also a dimorphic fungi, but typically they have a lot of spores more commonly seen than the hyphae, which is surrounded by a dense neutrophilic infiltrate like we saw in the chromoblastomycosis case. Another unique feature is the presence of something known as the sporotrichosis asteroids, which are basically the same spores surrounded by a densely eosinophilic material radiating out like a sun rays. Please don't confuse this with an asteroid body seen in your sarcoidosis, which the appearance looks totally different, and they will not be highlighted by the past stain. The below picture is actually showing the past stain of the sporotrichosis organism. Like you can see here, they are not pigmented, and they're usually seen scattered like this. They're not seen in clumped or groups. The second differential would have been a blastomycosis. But then again, in for blastomycosis, usually endemic in different parts of North America or even some parts of India for that matter. But histologically also, they do stand out as being these very broad, large spores with broad-based budding. Another very rare differentials could be your coccidiomycosis, which is also endemic in the North America and South American countries. But these usually have a very characteristic appearance, very different from that of chromoblastomycosis. They are not pigmented. They have these huge, large spore-like structures in which you have these small endospores which are scattered. Another differential could be a mycetoma, but then again, the clinical feature would be very classic. The patient will be having an indurated, thickened skin lesion with a lot of discharging sinuses, which can drain either sulfur granules or particles from it. And that classically on histology will have something known as a splendor foci phenomenon, which is basically the fungi or the bacteria that is surrounded by a dense radiating appearance of debris, which is actually the reaction between the antigen antibody complexes and the inflammatory infiltrate around the organism. Now, mycetomas can either be caused by fungi, which can be stained by the GMS stain, or by a bacteria like actinomyces, and then we can see it by a Grams or a GM-SAS stain. Now, one of the common bacterial infections that can cause similar appearance would be tuberculosis in our country. Now, the classic skin involvement of TB is known as lupus vulgaris, and then again, the clinical picture is very classic. They will end up having these painful, disfiguring papules or nodules on the face that do have a tendency to ulcerate and disfigure the face. Zn stain is helpful to show the classic beaded appearance of the acid-fast bacilli. But one thing to note is that in the early phase of the lesion, the bacilli can be detected, but once granulomas become much more pronounced, then the bacteria will not be seen. Very rare differentials include cutaneous leishmaniasis, which is a protozoal organism. There you will see a lot of macrophages, which are seen with a lot of intracytoplasmic small rounded bodies, which are the A mastigotes, which can be stained more better with GM cell. A very rare differential would be a rhinosporidiosis. Rhinosporidiosis, for that matter, doesn't affect the skin. It usually causes polypoidal lesions in your nasal cavity or in the upper respiratory tract. But there are very rare case reports wherein by direct skin inoculation or by hematogenous or lymphatic spread, this organism can be seen even in your skin causing lesions. Now, classically, you will see something known as these big spore-like structures, which are called sporangia, which are filled with these tiny sporangiospores. Another differential could be filariasis. You'll be very lucky to maybe see the transection of the worm, especially the female worm like this, which is showing the a gravid state with microfilaria inside. Last but not the least, we have viral infections that can be confused because they form these verrucous lesions on the skin. These include the verruca vulgaris as well as the papillomas, which are usually caused by low-risk HPV infection. Now, in verruca vulgaris, you are seeing the classical picture of hyperkeratosis, columns of parakeratosis, and you're also seeing hypergranulosis and coilocytic chain, which is basically a resinoid appearance of the nucleus surrounded by clear vacuolated cytoplasm. Another classical feature of Verruca vulgaris would be the fact that the reader ridges will be going inside, that is known as the toeing in sign. The other differential would be a papilloma, but then again, the clinical picture would be that of a very filiform-like lesion with prominent fibrovascular cores. And the last but not the least, the differential diagnosis should be any malignancy. Because these lesions can sometimes be pigmented, one of the differentials would be a melanoma. But then again, in melanoma, the lesion will show a lot of pleomorphism. There will be intracytoplasmic and extracytoplasmic pigment. There will be pagetoid spread. There will be a lot of pleomorphism and prominent nucleoli. Another, but last but not the least, another differential should be a squamous cell carcinoma. But then again, clues like keratinization, intercellular bridging, overt atypia, pleomorphism are all clues to help us pick out squamous cell carcinoma. One thing to also note is that in very long-term cases of chromoblastomycosis, squamous cell carcinoma can be the end result. So if you do see a case of squamous cell carcinoma in a suspected patient who's a farmer, who's had a history of any trauma, and is having a very long duration lesion, you should also look for these fungal organisms if possible. So the take home message at the end of the PPT is that it's very crucial whenever you have a lump or a bump on the skin of people to correlate with the clinical history, in history of any travel, and the skin appearance. It's very crucial to discuss with the dermatologist about the skin appearance of these lesions. Very important to pick up the clues on the histopathological sections, and obviously special stains come to your rescue. Thank you.
Thank you, Dr. Ansar. Can I request Dr. Purnima to present the case C4 from St. John's Medical College, Bangalore? Dr. Purnima. You'll be here only. It will take 5 minutes.
Hello.
Yeah, doctor.
Yes, ma'am. Shall I start?
Start.
Good afternoon, ma'am. I'm Dr. Purma from St. John's.
Doctor, your voice is breaking.
Hello.
Yeah, doctor.
Yes, ma'am. Am I audible now?
Yeah.
Yes. So today I'll be presenting case number C4 with a history of a 45-year-old male ultraproliferative growth in the retromolar region around 3 into 2 centimeter in size with history of squamous cell carcinoma of external auditory canal. So on the scanner view, we could see section shows.
Doctor, we can't see your slide. I'm sorry. We can't see.
Hello.
Yes.
Ma'am, can you see the screen?
I cannot see. Can others see?
Repeat more. Um, can you stop sharing or have you done it? Yes. Share again. Yeah.
Dr. Answer, if you're back, I think you can share your screen and take over.
The thing is, I'm presenting from home, so I'm not put up a screen. That is
Dr. Aditya, she has finished already. I'm waiting for
Done.
Dr. Purnima to start her screen
Done.
sharing.
Dr. Purnima?
Yeah, sir, I'm sharing my screen, but they're not able to
Yeah,
see my slide.
and now it's visible.
The thing is, Dr. Purnima, you have not shared the entire screen. That's why if you put it on a slideshow, it's okay. Now you go and go ahead.
Okay, yes, thank you. So yeah, this is the scanner view where it shows section shows buccal mucosa, which is lined by stratified squamous epithelium, where there is no evidence of dysplasia. The subepithelium shows a circumscribed ulcero infiltrative neoplasm.
On higher magnification, we can see that these cells are in monomorphous population of large round to polygonal neoplastic cells, which are arranged in sheets. So, and these neoplastic cells exhibit vesicular nucleus with the prominent peripheral place nucleoli, fine chromatin, and scant cytoplasm, and also seen the mitotic figures. And these neoplastic cells are also seen infiltrating into the skeletal muscles. So, based on my histopathology examination, my provisional diagnosis could be high-grade malignant neoplasm, in which my differentials are: first is non-Hodgkin's lymphoma, neuroendocrine carcinoma, and non-keratinizing squamous cell carcinoma for nasopharynx. So in non-Hodgkin lymphoma, we have, I was thinking of DLBCL and plasmablastic lymphoma. In DLBCL has diffuse large B cell lymphoma. The large cell itself, which favors the features. It has large cell with monomorphic population, prominent nucleoli, and high mitotic activity. Features which is not favoring for this is the patient came with the complaint of ulceroproliferative growth in the retromolar region, but whereas DLBCL usually arises from the lymph node. So here I would run few IHC markers, that would be CD20, PAX5, CD79A, which all will be positive and will be negative for CD138, CD38, CD3, cyclin D1, and TDT. So plasmablastic lymphoma. So this is my another DD, where this also have plasmablast to immunoblastic cells. They also have high mitotic figure, and the common location is the oral cavity. But here the patient is not giving history of HIV, but still I'll run some IHCs to rule out my diagnosis. So CD138 and CD38 will be positive. MUM1 and IRF4 will be also positive. CD20, PAX5, and CD79A will be negative. My next DD is neuroendocrine tumor. In my mind, there is large cell neuroendocrine carcinoma and Merkel cell carcinoma. In large cell neuroendocrine carcinoma, again, the cells are large with vesicular nucleus with prominent nucleoli. But the characteristic feature of a neuroendocrine carcinoma is salt and pepper chromatin, which is absent in this slide. And also, we see a moderate cytoplasm and there are no areas of necrosis. And large cell neuroendocrine carcinoma usually arises from lungs. So, but still we'll run some IHCs for that is chromogranin A, cytophysin, and CD56, which all will be positive. My next DD is Merkel cell carcinoma. So again here the feature is it has a vesicular nucleus with prominent nucleoli, scant cytoplasm, and necrosis are not seen. But the features which is not favoring Merkel cell carcinoma is the size of the neoplastic cell, which is intermediate size with the salt and pepper chromatin. So here also I'll run few IHC markers: chromogranin A, cytophysin, CD56, and CK20, where CK20 shows a classical pattern of dot-like pan-nuclear pattern, which is a classical IHC for Merkel cell carcinoma. My last DD is non-keratinizing squamous cell carcinoma of nasopharynx. Here we can see the cells are large with absence of keratinization, which I thought of non-keratinizing squamous cell carcinoma. But the features which are not favoring is the hypochromatic nucleus should be there, and inconspicuous nucleoli should be there in squamous cell carcinoma with moderate cytoplasm. But here also I'll run some IHCs, that is P63, P40, and CK5R6, which all three will be positive for squamous cell carcinoma. So based on my histopathological examination, these are my DDs. Thank you.
Fantastic, Purnima. So I'll just share my screen now.
Yes, ma'am.
Sorry, so I have to go to share screen. KCIAPM here. Which window? Window.
Click on share screen, tap entire screen. Yes.
1 second. No, first I'll have to go for that large now.
Entire screen.
God. I have to go here, share screen, window.
No, not window, ma'am. Select entire screen.
Okay, entire screen. Okay.
Then tap on that screen. Then the share button will get activated. And
Yeah.
click on share. Yes. Now we can open the pop.
Is it visible?
Yes, ma'am. Go ahead.
Yeah. So good afternoon, everyone again. So Purnima has already done a very, very fantastic presentation. So I'll be just sharing few more details about the case. Am I audible to everyone? Hello?
Yes, ma'am.
Yeah. So this was a 45-year-old male patient who presented with the mass in the retromolar region since 1 month. Actually, this patient had a past history of a squamous cell CA in the right external auditory canal, for which he had even taken complete treatment, including an RT. So this was he had come after the complete treatment. He came to our oncology department with the 3 into 2 centimeter growth, which was observed there. They did the regular investigations, radiological, and they found that the underlying mandible, was completely uninvolved, and they could pick up some lymph nodes on a PET CT. So when we received the specimen, this is how the HND looked like. So I think already you people have seen, and Purnima has already discussed this morphology. So the cells had they were round cells with a uniform stippled chromatin and very inconspicuous, very scanty cytoplasm, very brisk mitosis. Two of the nodes came out positive. So, as you all know, the first thing was it's a round cell tumor, which is very, very evident from the slide. So, it's a round blue cell tumor. Now, since this patient had, there was some confusion because he had a past history of a squamous cell CA. So that was also in our mind. But based on the morphology, as you guys have rightly put it across, I was going through the differential diagnosis. So this is what would come up in everybody's mind. I mean, even you are PG, still it for us also. These were the only differentials in our mind. That it could be a lymphoma, diffuse large B cell lymphoma. Definitely, you people have five of you have given that. Then large cell neuroendocrine. Definitely, that is one of the differential. I think quite a couple of you people have given that diagnosis. Then, of course, a squamous cell CA. So we already had a history of squamous cell CA. So we were actually, in fact, thinking whether it is again the same thing. Some of you gave a NUTCA carcinoma. Melanomas, of course, any case can obviously come as a melanoma. It can come anywhere. One of you gave it as an Ewing sarcoma, and I saw a diagnosis of a lymphoepithelial CA from two of you guys. So same thing, we had most of these things in mind. So based on that, we had kept a IHC, we kept a battery of tests we had run. So to our surprise, CD45 was completely negative. So all the lymphoma spectrum was ruled out. P63 was ruled out. So squamous cell CA was ruled out. So it's become very easy now. Once you do all the IHC, you are able to rule out most of the things. We had a differential of a plasmablastic lymphoma in mind. So along with 45, we had actually done a 138 for this patient. That came out negative. Melanoma was ruled out because S100 came out to be negative, and neuroendocrine was ruled out because synaptochromo turned out negative. So, to our surprise, the two things which came positive were CD99 and NKX 2.2. So, one of you who had given a diagnosis of Ewing's, congratulations. So, NKX 2.2 came positive and CD99 came positive. And we then send the thing for a fish, we send the tissue for the fish. And to our surprise, it came out to be extraskeletal Ewing sarcoma. So the fish demonstrated the presence of a EWSR1 FL1I fusion, and that confirmed the diagnosis. So this turned out to be an extraskeletal Ewing sarcoma. So the whole idea of presenting this case was a very unusually, normally when such a tumor comes and with the previous history of squamous cell CA, the first thing which comes to your mind is actually not an Ewing sarcoma, and extraskeletal though never comes in mind. So that is the reason why we showed this case. was that whenever you get such a round blue cell tumor in this site, these are the battery of tests you should always order, because now ISCs are available. So you can always put this entire spectrum of lymphomas and the neuroendocrine tumors and the rounds other osteosarcoma like tumors before coming to a diagnosis. And nowadays, without molecular diagnosis, nothing is complete. So always try to get something like a fish or a PCR done for all these cases. So, as far as extraskeletal Ewing's is concerned, or Ewing's tumor is concerned, is the second most common malignant bone tumor in children and young adults after osteosarcoma. The male to female ratio is 1.5 is to 1. Nearly 80% of the patients are less than 20 years, although our patient was a mid-aged guy. And younger than 5, it is not very common. The most common sites are the pelvic bones, the ribs are very common, the diaphyseal region of the long bones are common. Bones are definitely more common than soft tissue. And approximately only hardly 12% of all these cases turn out to be extraskeletal. So the primary mutation generates a fusion gene between the FET and the ETS families, altering the gene expression and promoting tumorigenesis. And majority of these mutations are sporadic, however, the germline have been reported. So etiology, it's arising from the mesenchymal stem cell, and as I already discussed, there's the chromosomal translocation, which involves the EWSR1 and the ETS partner. Diagnosis radiologically, usually if it's a bone lesion, it's picked up faster, and if it's an extraskeletal, definitely you have to go for the labs as well as the histopathology. In the lab findings, anemia, they are generally the patient might present with an anemia, leukocytosis, and an elevated ESR. Radiologically, the findings in a case of a bone lesion are far more specific and significant, like an osteolytic permeative lesion, a moth-eaten bone destruction, aggressive periosteal reaction. So, if it's a bone lesion, definitely I always request the postgraduates to always go to the radiology department, because nowadays the majority of the times the oncology teams, they do a PET CT and they do a lot of extensive radiological investigations, and these are very helpful when you want to sit and diagnose such atypical cases in your lab. So CT MRI will always help you to assess a metastatic disease. So regarding the types of Ewings, all this is available. You can have a classing Ewings, like how we were seeing the tumor cells were almost double the size of lymphocyte, round nuclei, finely stippled chromatin. And then you can have atypical Ewings, which will have a little bit of irregular nuclear contours, vesicle or a coarse chromatin, prominent nucleoli. And then you can have an admantinoma-like pattern in a Ewings, in which you can see nests of basaloid cell with peripheral palisading and cording. So, as I told you, molecular and cytogenetics is extremely important when you diagnose such cases. So, always send the sample to look for a translocation. Without that, I will really recommend, please do not give any diagnosis with like a synovial sarcoma or a Ewing sarcoma without doing these translocations. Otherwise, the long term issues are always there regarding treatment and recurrences. So what could be the, we have already seen what were the possible differentials in this case. We saw that the neuroendocrine tumors, they were the most likely, as well as the DLBCL, the lymphomas, and the squamous cell CA of a basaloid type was a possible differential. Then there are some other differentials also which could you can think of, will be an alveolar rhabdomyosarcoma. But again, IHC is definitely a very helpful thing. You can do a desmin myogenin, which will be positive in a rhabdo, not in our case. Then you can have a desmoplastic small round cell tumor, but that will be WT1 positive, again 99 negative. Small cell osteosarcoma, in fact, we actually did an IHC for that, but we had a SAT-B2 negative. In osteosarcoma, it should be SAT-B2 positive. High grade neuroendocrine, we have already discussed. You know that synapto, chromo, INSM1, all these battery of neuroendocrine uh, ISCs are available nowadays. And of course, if there is any confusion, then obviously the molecular part always suffices. And then, of course, anywhere you can have a poorly differentiated synovial sarcoma, a round cell sarcoma with EWSR1 non-ETS fusion. So there are some more of all these differentials which you can always, but you can do your minimal IHC workup first, and probably only if all that is negative, then you can definitely go for the high end investigations. Thank you so much. If there are any questions, I'll be happy to answer that. Can we move on to the next case, please? Hello?
Yes, ma'am. I think please stop sharing so that.
Yeah.
Doctor Shashwat can present the case.
Yes, sir. Am I audible, sir?
Yeah, you're audible.
Yes, sir.
Sir, I'll share my screen.
Shashwat, please click on share screen and then select entire screen.
Yes, sir.
You have to tap on the screen after selecting the entire screen, then click on share.
Yes, sir. Sir, is my screen visible, sir?
Yes, put it on slideshow mode.
Yes, sir. Good evening, everyone. I have been nominated from AIMS BG Nagra. I'm Dr. Shashwat.
Shashwat,
I'm
wait.
a second year.
You're not sharing the screen. Stop sharing.
Stop sharing, sir.
Yes, share entire screen, not the window.
Sir, it is not letting me click on that option.
That's why click on share screen, entire screen, then tap on the screen.
Then tap on the screen. Okay, okay, sir. Yes, sir. Yes, sir. It worked. Sir, is it visible?
Yes, share a screen now. Open a
So,
PowerPoint.
good evening. So, good evening,
Slideshow mode.
everyone. I'm Dr. Shashwat. I'm a second year postgraduate from AIMS BG Nagra. I have been given case number C5. The history is the patient is a 58-year-old female whose anemia is under evaluation. 3 slides have been provided: a peripheral smear slide, a bone marrow standard slide, and a bone marrow pearl stain slide. So these are the 3 slides on scanner view. So in the peripheral smear, the findings are that the RBCs are microcytic hypochromic, and they show mild anisocoagulositis. The WBCs appear normal in number with slight shift to left. Platelets are adequate but seen in clumps. So my impression is that it is microcytic hypochromic anemia. Then moving on to the bone marrow slide. So in the bone marrow slide, I found this erythropoietic cells. So these cells, these erythropoietic cells, show cytoplasmic. If you focus on the arrow here, cytoplasmic projections, blebs, and vacuoles. Again, in this picture also, cytoplasmic projections are noted. Same in this picture. You can see cytoplasmic blebs coming from the cell. Then also what I noted was nuclear budding. The nucleus appears to have 3 different lobes. Yeah, so the bone marrow sample was adequate. It was normocellular, and so to recapitulate all the findings, uh, the myeloid to erythroid ratio was reversed. That means there were a lot more erythroblasts than myeloid series precursor cells. The erythroid series precursors were increased in number, and features of dyserythropoiesis were noted in the form of binucleation, that is, some binucleate RBCs were there, nuclear budding, nuclear bridging, along with cytoplasmic blebbing, cytoplasmic projection, and cytoplasmic vacuolations. A few megaloblastoid cells with C-like chromatin were also noted. The myeloid series were decreased in number, but they showed a normal maturation. And I also noted that the megakaryocytes were normal in number, but they were hypolobated. So my final diagnosis after all these findings is myelodysplastic neoplasm. Thank you.
Okay, Shashwat, fine. So your diagnosis was myelodysplastic syndrome. Is it so?
Yes, sir. Yes,
Okay.
sir.
So let me share my screen and I will just take you to the images. Is my PPT visible?
Sir,
Not yet.
You want to stop sharing?
I think again you have to share your entire screen. Please click on share screen and then entire screen. Dr. Nagarjun,
Yeah, sir. Yes.
if you tell me the issue, I'll be able to help out. No, no, this is not the one. Click on stop share. Please stop sharing. Was this entire screen?
No, sir.
Please select entire screen option.
Full screen. Then
Tap on
share.
the screen. You should tap on the screen for that to become active. Once you select entire screen, a screen pops up which you'll have to select. Then the option is share option gets activated. Yes, now open it.
It's visible. Okay.
Yes, yes, go ahead. Slideshow mode, please.
So this was a case of a 58-year-old female evaluation for anemia. So first time when you get a marrow, the first thing that you have to comment is look for the cellularity. So Shashwat, so what was the cellularity in this case was around mild to mildly hypercellular marrow. And the first thing that you have to look for is that in a marrow smear that you look for megakaryocytes to make sure that marrow is adequately represented, that particles have been aspirated. You look for megakaryocytes and adipocytic tissue. I'm audible?
sir. Yes, sir.
Yeah. So here in this image, you're able to see a megakaryocyte along with other hematopoietic elements. So always comment about cellularity when you see a marrow first. Okay. And now I've tried to highlight the erythroid series as you have explained that you're noticing this erythropoiesis. Certain megaloblastic change has been highlighted here. And the subsequent image, again, you can see nuclear irregularity and a budding that is noted here. And again here, you can appreciate binucleate forms here. Okay. So with all these findings, apart from this, there was no significant dysbiosis in the myeloid series or megakaryocyte occasional hypolobated forms were there. So with these findings, the common thing that comes to your mind is there's dysbiosis in erythroid lineage. I've intentionally not put the peripheral smear. I will be taking it in the next subsequent slide. So these are the differentials that run in our mind. Always MDS should be the last in a differential, and we have to think about the commonest causes for secondary myelodysplastic changes. So the commonest one is the B12 and folate, heavy metal toxicity, any drug-induced drugs causing myelodysplastic changes, any growth factors, hypothyroidism, CDA, protein energy malnutrition. So you have in numberable conditions that can result in myelodysplastic changes. So you need to be aware before you could stamp any case as MDS. Now I will show the next slide. Can you please tell me what are you appreciating here, Shashwat? Peripheral blood, peripheral smear findings. Anything specific you can make out?
Sir, I see some of the RBCs are a little purple, so is that basophilic stippling, sir?
Yeah, basophilic stippling. I am very sorry. Probably in the scanned images, I don't know how many of you could appreciate. I mean, it was very tough for me. That is why I shared these images. So can you appreciate this now?
Yes, sir. Yes, sir.
Yeah. Again, you can see these basophilic stippling, that is punctate basophilia, all around the RBCs. So now what do you think, what do you want to consider now with these findings of a bone marrow and a peripheral blood findings? Anything you want to suggest?
Just from
Shashwat?
basophilic, so just from basophilic stippling, I would consider lead poisoning.
Yeah, you need to consider lead poisoning. Okay, any other differentials for lead for basophilic stippling? Any other conditions?
Sir, megaloblastic anemia.
So, okay, fine. Even megaloblastic, I will just explain it. So these were the diagnoses that we received. Majority of them have called it as myelodysplastic syndrome, and I think the Pearl stain I have not focused it here, but it was evidence of iron overload was there. But I'm not very sure whether ring sideroblasts how many of you could appreciate in this. But majority of you have committed as myelodysplastic syndrome, and I think two of them have called it as Vivax. I think you had a very eagle-eyed vision to pick up these. Probably that is what I'm presuming. The stippling was taken as a parasitic involvement. So okay, fine. And then some of them have called it as CDA, that is congenital dysphotic anemia, and one for megaloblastic anemia. So one thing I would like to tell in CDA is that generally they present at quite younger age, not presenting at this elderly age group, and then more or less they will have other systemic symptoms like jaundice and organomegaly will be present in that. So with this picture of peripheral findings and the bone marrow findings, the first thing should be that causes for basophilic stippling has to be ruled out. So these are the blue granules composed of RNA showing occurring due to impaired hemoglobin synthesis. So these are list of conditions such as lead poisoning, thalassemia, alcoholism, sideroblastic anemia, arsenic poisoning, megaloblastic anemia. So even MDS for that matter you can see, but the commonest that tops the chart is lead poisoning. So one of the different mimicker of this basophilic stippling is that papinemer bodies. So these are nothing but iron-containing mitochondrial remnants, commonly seen again in and they won't be this uniformly scattered. One or two granules will be there eccentrically located. So these are noted in sideroblastic anemia, iron overload, thalassemia, megaloblastic anemia, post-splenectomy, or even MDS. So after these findings, we suggested the clinician to just get an heavy metal panel workup done, and finally, our suspicion was supporting with these reports where the lead was markedly elevated in the patient and even with aluminium overload. And after all this, once the patient was again taken a detailed history was taken, and then he's committing that he was taking Ayurvedic or herbal medications for quite a few years. So now here I mean, once you start digging into the patient clinical history, half of our work is sorted out. And now this, after getting your heavy metal workup, and then the patient is telling that he was taking this herbal medication. So whenever any case that comes, proper detailed clinical history will sort out all our problems. So the take-home message from this slide was that don't ever stamp any MDS without clinical or a drug history. Now you may be asking, how do I stamp this report when you don't have all these details at first go? So generally what we commit is that we tell the marrow, commit on the cellularity, and we tell dysbiosis is noted in what kind of lineage. In our case, it was just erythroid dysbiosis. And because we found a basophilic stippling, we were suggested that please get a at first go, our differentials was again, we had mentioned that one could be heavy metal poisoning, other things could be any CDA, and the last thing, when everything is ruled out, MDS, primary MDS could be considered. So always view up for the residents, this is the take home message. Always view a marrow with the proper clinical details and always start with peripheral smear. I think had you seen just the peripheral smear, most of your diagnosis would have been sorted. And in this case, I'm very sorry, probably we're not able to pick up in the scanned images that well. So always start with peripheral smear. I remember as an undergraduate myself, we were so excited. Always when a marrow comes, we start with the aspiration first go. That should not be the way you approach a case. Always start with the history. Don't touch the marrow without history. Look into a peripheral smear, see all your CBC details, and after that you look into the marrow. So doing this in a systematic way, you will be able to come to a proper diagnosis. So yeah, next candidate, Aisha. Any doubt, Shashwat?
No doubt, sir. I think I mistook the basophilic stippling for polychromatophils when I saw it.
Okay, fine.
Thank you, sir.
Can I share my screen, sir?
Yeah, please share your screen.
Sir, is it visible?
Visible.
Good evening, everyone. Myself, Dr. Asia, postgraduate from Belgaum Institute of Medical Sciences, Belagavi. We have been allotted case C6. So, history given is 43-year-old female with complaints of anemia and weight loss, biopsy from ulceroproliferative growth in the stomach and colon. PET-CT shows metabolically active lesions in thyroid, cervical nodes, bilateral breast, adrenal, stomach, kidney, brain, uterus, bilateral adnexa, skeleton, and peritoneum, subcutaneous and intramuscular deposits. So the given slide has two sections showing multiple tissues. So coming to the first section, it shows colonic mucosa and the tumor. We can see in the low power ulcerated mucosa with the tumor cell destroying the glands with mixed inflammatory cell infiltrates. These tumor cells are arranged in sheets and fascicles. These tumor cells are spindle to epithelioid with fine dispersed chromatin, small nucleoli, and eosinophilic to clear vacuolated cytoplasm. There are areas of necrosis and abnormal mitotic figures are seen, which are 1 to 2 per 5 square area. Adjacent colonic mucosa shows sparse inflammatory cell infiltrate. Coming to the second section with the multiple biopsy fragments, showing the gastric mucosa with the submucosal tumor. On further high power, we can see the ulcerated mucosa with the tumor destroying the glands. We can see mucosal gastric glands with the tumor cell infiltration. These tumor cells are arranged similarly in the sheets and fascicles with similar morphology, which are spindle to epithelioid with fine dispersed chromatin, small nucleoli, and eosinophilic to clear vacuolated cytoplasm. There are areas of necrosis and hemorrhage and abnormal mitotic figures counted as 3 to 4 per 5 square area. To summarize, multiple biopsy tissue from the colon and stomach shows ulcerated mucosa with a submucosal tumor arranged in sheets and fascicles. These tumor cells are spindle to epithelioid with fine dispersed chromatin, small nucleoli, and eosinophilic to clear vacuolated cytoplasm. There are abnormal mitotic figures. Stroma is scant, made up of fibrocollagenous tissue with sparse inflammatory cell infiltrate. There are areas of necrosis and hemorrhage noted. The probable diagnosis is gastrointestinal stromal tumor. Further, this gastrointestinal stromal tumor can be associated with many syndromes. Few of them include Carney-Stragatakis syndrome, which includes gastrointestinal stromal tumor with paraganglioma, and non-hereditary Carney's tired, which will have gastrointestinal tumor along with pulmonary chondroma and paraganglioma. And it can be familial GIST syndrome, with which these tumors are aggressive with KIT and PDGFR germline mutations, and sometimes it can be associated with neurofibromatosis, which present with multiple GIST. So the one of the differential include MEN 2A or B syndrome because of the multiple sites of metabolically active lesion, and also the neuroendocrine tumor is submucosal in lesion. However, the nuclear features are not classic of neuroendocrine tumor, lacking the salt and pepper chromatin. So IHC for the neuroendocrine tumor has to be done, which are chromogranin, synaptophysin, and neuron specific enolase. Further workup for confirmation will be IHC markers are KIT or CD117, DODGE1 or ANO1, and neuroendocrine markers to rule out MEN syndrome. And molecular diagnosis would be can be done for KIT and PDGFR mutations, SDH deficient mutations which are wild type, and to rule out neurofibromatosis 1 NF gene can be done. Thank you.
Is my PPT visible?
Yes, sir.
Okay, fine. Okay, well presented, Aisha. So let me just take you down through this few more slides. So, a history of multiple ulcers with ulcer proliferative growth. So patient was evaluated because she was having anemia and complaints of weight loss. And as you when we saw the biopsy, you're seeing spindle-shaped cells, more or less. In this low part, you can see vague fascicular pattern and spindle-shaped cells that you're able to appreciate. And this is again another view of this. And there's an again other view of it. And remaining pictures, I think you have beautifully showed the histopathology images with mitosis, necrosis, and normal colonic and the gastric mucosa that is there. So this was a non-causal growth pattern with large oval to round cells. Sometimes some of them are looking spindle-shaped with abundant eosinophilic cytoplasm. More or less uniform-looking cells, which are kind of indented and grooved or irregularly folded, which I would like to tell, and with a vesicular chromatin and distant nucleoli. So this was the histomorphology that was there. Now with this histomorphology and the clinical data that we are having, always we would want to rule out the commonest first, that is the carcinoma, and being a gastrointestinal tract, of course, yeah, just as you have mentioned, and a lymphoma as well. Okay, so this was a primary panel. Always in IHC, you don't put all the markers at one go. You have to have a certain list of differentials and try to narrow it down. So this narrowing is possible only when you put a broad spectrum antibodies at the initial primary panel, whether to know it's a carcinoma or a lymphoma or a sarcoma or a hematolymphoid malignancy. So this was the first panel that we put, PAN-CK117 and LCA. And what was the answer with this first panel? PAN-CK was negative and CD117 was negative. And LCA had come patchy positive. Okay. So with this, we went on to a secondary panel. That is, we added S100. S100 was added that we wanted to rule out melanoma. CD1A was added because of these kind of folded cells, vague spindle-like appearance. We just wanted to rule out LCH. Then, of course, again, neuroendocrine tumor, we wanted to rule out that is synaptophysin, neuroendocrine carcinoma. And of course, always when LCA comes patchy, or sometimes even if it comes negative, still we always go ahead and do a B cell marker commonly. That is CD20 was done and CD3 as well. And a stem cell marker, that is CD34 was done, to thinking of any other immature hematolymphoid malignancies. And CD68 was done to make sure that we are not losing out on any histiocytic lesion. And CD23 also was done to look out that we are not losing on any hematolymphoid malignancy. That is a follicular dendritic cell tumor. So I will just take you through before going to IHC, this was a PET CT images. So you can appreciate the entire body is studded with these deposits all over the body. That is why I made sure that the PET CT images, the finding is given. So you can you appreciate the PET CT image, Aisha?
Yes, sir.
Yeah, seeing this PET CT images now, do you feel it could be just forget doing IHC and calling it as just negative? So what do you feel? Just can present something like this?
Sir, in advanced cases, it could have multiple meds.
Meds, no, I mean, it's involved every bone, every muscle, soft tissue, thyroid, you name the organ. That is why I mentioned PET CT. This kind of presentation is almost a no in a gist. It doesn't present in this aggressive manner, and these are small nodules. Okay, so that is one thing. That is why I made sure that you need to have a entire clinical details in your background. So if just is ruled out, one thing is carcinoma, or in other possibilities are hematolymphoid malignancies. Sarcoma is also very unlikely to give a diffuse involvement of this pattern. So I'm just showing you the IHC picture, CD45, though not a diffuse positivity, patchy positivity for CD45. Then CD68, that is the histiocytic marker, has come diffuse positive. And beware with CD68, always if just a CD68 marker and you're trying to commit as a histocytic lineage or anything, it's a big no. You need to rule out all the other differentials and have another marker to support histocytic nature. So in this case, we went ahead and put CD163, which is again come patchy positivity, and CD4 also. You can see the tumor cells have taken positivity for CD4. Now with this IHC, can you think about what do you think your differential will be? Aisha, anything you could narrow down? Aisha, are you able to hear me?
Yes, sir.
Yeah, any differential you want to suggest now? See, I don't want
Sir,
any diagnosis from you. I just want to know how well are you approaching the case. So that is what is the entire purpose of this case presentation. So uh, with this IHC marker, I just want you to know what differentials are there in your order. And now with your markers that I'm showing, what do you think?
sir, T cell.
What is CD68? I told it's a histocytic marker, and other T cell marker CD3 is completely negative. And only thing is patchy CD4 has come positive. Okay, so with this kind of expression in our mind, we thought it could be a histocytic lesion with the morphology that is there and the diffuse involvement all over the body. So our possibility was a histocytic lesion. So this was the diagnosis that we received. That is just was a majority. Then melanoma, carcinoma, LCH. LCH. That is why we put LCH can be a very good differential, but CD1A was negative. And some two of the candidates have given histiocytic sarcoma, granulomatous lesion, follicular dendritic cell sarcoma. Yeah, appreciate you people. And another person is called invasive lobular carcinoma. So carcinoma is completely ruled out. So based on the marker expression, it was a histiocytic sarcoma. So it's a malignant tumor. Extensive involvement, the patient actually succumbed almost after 6 months. 3 to 4 months after the diagnosis. So basically, this is a tumor that is not very common. But once you rule out all the common entities, these uncommon entities should strike you. You know the kind of clinical presentation. What at least the gross, it's a hematolymph or a carcinoma. You need to come up to that segregate at that level at least, so that we could work up in an appropriate way in the subsequent panels. Okay, so thank you. Any doubts do you have? Anyone? Any doubts? So I think I'll hand over the keys to Suneet ma'am. Ma'am, could you please take over? Hello.
Yeah, Gajan, yeah. So I think now we have to start with S4 case. Uh, who is doing the S4? Can you please come forward? Dilip, I think Mr. Dilip Loni.
Ma'am, am I audible, ma'am?
Yeah, you are audible, Dilip. Please carry on.
Ma'am, is my screen visible?
Yeah, it's visible.
Ma'am, myself, I'm Dilip, second year postgraduate from Yanapoya Medical College. So the clinical history was given is a 22-year-old male patient came with complaints of abdominal pain and constipation. Query IBD was given as the clinical history. So in this low power, we can see that uh, the colonic mucosa is fairly maintained with the crypt architecture, and here we can see some lymphoid collections also. And when we go to higher power, here we can see that lamina propria is showing some lymphoid collections, and here also we can see we can appreciate some granulomas. In this view also we can see some granulomas and collection of lymphoid aggregates. As we go higher power, these granulomas, in these granulomas we can see predominantly eosinophils are seen with some lymphoid collection. Here granuloma is again seen with a few eosinophils. Here, granuloma is centered with one parasitic ovum and with a few eosinophils. And in this granuloma also, it is centered with parasitic ova. And here we can see some collection of lymphoid as well as eosinophils are also seen. So based on the findings, it is a colonic mucosa. We saw some lymphoid collections and parasitic ova is seen, and granulomatous inflammation is seen with epithelioid histiocytes, some lymphocytes, and predominantly eosinophils, and focal areas of necrosis are also seen. So based on these findings, some of my differentials are Crohn's disease. So as caseating granulomas are absent and cryptic architectural distortion is also absent, and we saw parasites. So based on this, I have ruled out the Crohn's disease. And as we didn't see any caseation in the granuloma, and with the presence of parasite, I have ruled out tuberculosis. And I didn't see any foreign material, and granuloma is centered with parasite, so I have ruled out foreign body granuloma. And my last differential is sarcoidosis. So sarcoidosis is rarely seen in colon, and no systemic findings were also given. And here eosinophils are seen and parasite is seen, so I have ruled out sarcoidosis. So my final diagnosis is infectious colitis, chronic intestinal schistosomiasis, could be Schistosoma mansoni or japonica. So, thank you.
So fantastic, Dilip. You have nailed it already. I'll just add a few more things. Let me share the screen. I think window, entire screen. Can you see now?
Yes, ma'am.
Uh, this was a case of a 22-year-old male patient. Actually, he came from the Middle East somewhere. And the main complaint this patient gave was blood in stools and anemia. And he had diarrhea which was not resolving. So actually, the clinician gave us a rectal biopsy. So we have a very active gastroenterology department here in Fortis Hospital, and we get regularly maybe 10-20 biopsies per day only for the GI. And we have recently seen a lot of increase in incidences of IBD we come across very frequently. So the diagnosis was an IBD versus an infective. So, I mean, what slides actually what we shared to you, they came after several deepers. In fact, when we got the first set of slides, we could actually only see the granulomas. And there was the structure what we are seeing now in these slides, the parasite was not at all visible initially. And we were actually very confused that what are we dealing with, and schistosoma was never in our mind initially. We were actually thinking that they are so well formed punched out granulomas. We don't see that in Crohn's, we don't see that in TB, and there are so many eosinophils. Because of the so many eosinophils around and such a punched out lesions what we were seeing, we got a couple of deepers done. So that's how, whenever you are in doubt, always go for deeper cuts and serial sections. They always help you to solve a lot of problems in pathology. So when we went for the deepers, we saw all the structures coming up, and we could see the spine, lateral spine like structure. And so we came to a diagnosis that definitely it's a schistosomiasis. And since it's a lateral spine, so this is nothing but a schistosoma mansoni. Well said, Dilip. So the first thing, since it's you can see a clear-cut parasitic structure there, the ova is sitting there along with the giant cells and the reaction around. So definitely, if you see it in the first instance, you cannot rule out a parasite. But definitely, whenever you are dealing with a GI biopsy, the first thing which comes to the mind is definitely an IBD. So Crohn's has to be ruled out in all cases. but definitely in Crohn's, you will look out for other things like a cryptitis, a cryptapsis, the distortion of the mucosa. You will look out for the microgranulomas and cryptgranulomas. You look for a thickening of the muscularis mucosa. Nothing was there. When we think about a tuberculous lesion, you need those large coalescent granulomas. You look for Langerhans type giant cells. You look for caseation and a lot of granulation tissue. So that's what granulomas in colon can be really troublesome, and we really face a lot of issues regarding that, because even if you do a AFB to rule out a TB, most of the time it never turns out positive. So then we tell them to go ahead with a TB PCR and do all the other testing. Then of course a suture granuloma, or the fungal, we usually don't see that common, but definitely some of those parasites. And the suture granuloma can be there, but then the patient should have some past history of a surgical lesion or something. And as Dilip pointed out, a sarcoidosis, but definitely again you need to have a systemic involvement, and there should be a precedent history to all that. So anyway, since we could look for this parasite, it came out to be schistosomiasis. In fact, we did a ZN stain for this, and it turned out to be positive. So when we did a ZN, it became positive, and that is how you distinguish the Cystosoma mansoni from Cystosoma hematobium also, because mansoni will take up the ZN stain, whereas hematobium will not take up. So mansoni eggshells are ZN positive, and the past stain, if you see, hematobium will be negative for the ZN. So since this patient was from Middle East area, so you should know, Dilip, that most of these cystosoma, they are endemic in the Middle East, and especially if you see the Nile River and the North African region, they say whoever takes a bath in the Nile, he finally succumbs to cystosomiasis. So it's that common. But usually when these patients come, they usually come with some bladder infection and bladder lesions with cystosoma hematobium, and then we usually expect them to be there. But why I wanted to present this was little bit that in India, when we sit, we are not so familiar with these histosoma like lesions, especially when it is not in the bladder. And this was the clinician was not expecting, nobody was expecting, and as I told you in the initial sections, it was not there. It turned out only in the deepers, and the only treatment which patient took was a praziquantel. After traveling all the way to Middle East and come to India, he just took a praziquantel, and he turned out fine with all that. So I'll not go into much details about the cystosomiasis. You know already, I think you can read it up. The different type are the Mansoni, the Japonicum, and Hematobium. All of them are mostly endemic for the Africa, South America, and the Middle East parts. Sites are mostly the liver, intestine, bladder, uh, GI, and there can be many like spleen, brain, and spinal cord. And the presentation can vary. Sometimes acute presentation can be there. The patient might present with the swimmers itch, as I told you, in the Nile River. They usually get it once they enter the Nile. It is very commonly taken from there. So patients come with the swimmer's itch or a Katayamas fever. And chronically, once the lesion settles down, then they come with the diarrhea, intermittent abdominal pain, and a very poor appetite. Then because of the bleeding which they get, they develop iron deficiency, anemia, and colonic ulcerations as a result of the lesion. It is mainly the eggs which are the shells which are the problem, because they create this granulomatous reaction and later on ulceration. Otherwise the organism itself doesn't do much. So uh, I will not I'll not take much of your time, because it's a pretty straightforward case. And now I will request Dr. Anusha. Which case? S5. The person who is presenting the S5 case, he can start with the presentation. Hello. Miss Srinidhi, Dr. Srinidhi.
Is it visible, ma'am?
Let me check. And yeah, you are
Yes, ma'am.
visible too, sir.
Yes, ma'am. This is
Okay.
S5 and myself, Dr. Srinidhi from Ramaya Medical College. The clinical history given was 20-year-old female rectum biopsy. Upon the whole mouth view, we can see two polypoidal tissue fragments. We can also see that the lining epithelium, which is lined by columnar epithelium with interspersed goblet cells, show focal areas of erosion. Also seen is a normal colonic rectal epithelium. In the subepithelium, you can see granulation tissue with increased proliferation of capillaries and increased number of mixed infiltrates. Also seen are hyperplastic mucosal glands. Few are cystically dilated and there are many distorted glands. Within these few cystically dilated glands are mucus and inflammatory debris. And the stroma is edematous with mixed inflammatory infiltrates composed of lymphocytes, plasma cells, and moderate amount of eosinophils, about 38 per 10 hyperfield, and a few neutrophils. There's also focal areas of hemorrhage and congested vessels noted. The description is sections studied show polypoidal tissue fragments lined by focally eroded single layer of columnar epithelium with interspersed goblet cells. Also noted a foci of normal rectal mucosa. Subepithelium shows granulation tissue with hyperplastic mucosal distorted glands, few cystically dilated. The lumen of the glands are filled with mucus-like material and inflammatory debris. The edematous stroma shows moderate degree of mixed inflammatory infiltrate comprising of lymphocytes, plasma cells, and eosinophils, and few neutrophils. Also noted are focal areas of hemorrhage and few congested blood vessels. There are no evidence of dysplasia, arborizing muscles, thickened muscularis mucosae, granuloma, cryptitis, abscess, or malignancy seen in the section studied. And the impression is features of hematomatous polyp, most consistent with juvenile retention polyp. The differential diagnosis can be inflammatory polyp due to dense inflammation. It can also be secondary due to IBDs and other infections. Hence, we have to rule out for any cryptitis, cryptapses, and granulomas. And it can also be due to polyp secondary to the mucosal prolapse, where it will show thickened muscularis mucosae. Even Cowden's disease polyps will show a thickened muscularis mucosae. The other hematomatous polyp, that is Spitz-Ziegler polyp, will usually show a arborizing muscle, which has also been ruled out in my case.
Um, Thank you, Srinidhi. It was a nice presentation. Yes, it is a case of juvenile retention polyp. 1 minute, I'll just share my screen. Okay, so the history provided for this case was of a 22-year-old female, and rectal biopsy was sent to us. Colonoscopically, there was a solitary polyp measuring about 2 centimeter, and the rest of the colonic mucosa was normal. So on microscopic examination, see, this is the whole mount view, whatever we are seeing. So you can see the normal large bowel mucosa. This is a
Dr.
colonic.
Anusha,
Yes, sir.
just hold on, please. You're not
Yeah.
sharing your entire screen. Please share your entire screen.
1 minute, sir. Stop sharing and then.
Stop sharing and go back and share your entire screen.
Okay, sure, sir. 1 minute.
Select entire screen option, not a window.
Okay. Mm.
Once you tap on entire screen, just tap on the screen and then the share button will get activated.
Okay, 1 minute, sir. Yeah, share screen and
Entire screen.
entire screen
Tap on
and
the screen. A screen
okay.
has popped up there. Just tap on it once, then the
Yeah.
share button will get activated.
Um.
So now open your PowerPoint.
Yeah.
So now you can see.
Slideshow.
Yeah. Now.
Go ahead.
Yeah. Okay. Thank you, sir. So this is the whole mount view of the polyp, what we are seeing. So here we are seeing the normal colonic mucosa, and this is the polyp. So in as we all know, it is already juvenile retention polyp. So what we are seeing microscopically is a well-rounded and smooth contoured polyp, and we are seeing many. These are the crypts. These are the crypts of varying sizes. Few are dilated and few are normal appearing. So we'll go to a higher power. This dilated crypts will give a appearance of Swiss cheese appearance. So this is one of the pointer which we have to remember while seeing the slide. Next is in high power. What you can see is this is the lining epithelium which is completely ulcerated and it is covered with granulation tissue. And we can see these are the normal colonic crypts and these are the dilated crypts. So, and there is expansion of the lamina propria. So in higher power, when we see these dilated glands, these are lined by normal colonic epithelium as well as some flattened epithelium. And see, there are some collection of neutrophils within the glands also. This is called cryptapsis. So you can see cryptapsis in your juvenile retention polyp, as well as cryptitis can also be seen, because there will be lot of inflammation in the lamina propria, as you can see here, because here lamina propria will be expanded with mixed inflammatory cells, which you can see lymphocyte, eosinophil, neutrophils can be seen. So here you also can see this looks like serrated epithelium. This is because of the regenerative changes that is occurring in the colon. So you are seeing this serrated kind of lesion, but when you screen the entire slide, there is no dysplasia, and dysplasia should be commented, or it is significant when it is involving the surface epithelium rather than the crypts that is present within the polyp. So, young age, solitary rectal polyp, and on microscopically or in grossly, when you are seeing a very rounded, smooth contour, and also Swiss cheese appearance, that is varying sizes of the crypts, and ulceration of the mucosa, and expansion of the lamina propria with the mixed inflammatory cells. So, these all point towards the diagnosis of juvenile retention polyp. So juvenile retention polyp can be of two types. One is either sporadic or syndromic. This classification can be done only on clinical correlation. On microscopy or when pathologically, when we get this slide, we can just diagnose it as retention polyp or a hematomatous polyp that favors the diagnosis of juvenile retention polyp. So for discussion part, sporadic, it will be usually in a very young age, 3 to 10 years, and usually less than 3 polyps can be seen, and there will be no family history of juvenile polyposis, and there is no risk of malignancy. But we have to identify syndromic cases. So how do we identify syndromic cases let's discuss. It is usually autosomal dominant, and we'll see numerous juvenile polyps throughout the GIT. But most common site of occurring juvenile polyp is the colon, followed by stomach, followed by small intestine. So for the diagnostic criteria, you should have at least 3 to 5, more than 3 juvenile polyps in the colorectum, or juvenile polyps throughout the gastrointestinal tract, or any number of juvenile polyp with the positive family history of juvenile polyposis. After seeing the juvenile polyp microscopically, we should rule out other syndromes also, where we can see this kind of juvenile retention polyp can be seen in other syndromes also. So clinically, we have to correlate and we have to rule out other syndromic diseases. So why we have to identify the syndromic is because there is high risk of upper or lower GI malignancy, approximately 55% of the cases. So we have to identify these cases, and this patient should undergo yearly follow-up, and family members are also should be undergoing screening. So the germline mutation that is present in this case are SMAD4 and BMPR1A are the germline mutation. And 3 phenotypic groups can be seen in juvenile polyposis syndrome. That is juvenile polyposis of infancy, that is usually occurs below the age of 2 years, and it has a very poor prognosis. And juvenile polyposis coli, where the juvenile polyp exclusively occurs in the colon. And we have generalized juvenile polyposis, which can occur throughout the GIT. So
the juvenile polyps can also occur in other diseases. Which are the other syndromes where we can see this microscopic finding is, one is Cowden syndrome, another one is Cronkhite-Canada syndrome. At least in Cowden syndrome, we will not be able to distinguish microscopically whether it is related to Cowden syndrome or juvenile polyposis syndrome. However, in Cronkhite-Canada syndrome, we can see histologically in between the polyps, whatever the normal mucosa occurs, right, there will be crypt dilatation can be seen. So this points towards the diagnosis of Cronkhite-Canada syndrome. So these were the responses what we received for the particular case. So while giving a diagnosis, it's better to use a standard terminology, that is juvenile retention polyp. And I don't agree with ulcerative colitis because because in ulcerative colitis there will be crypt distortion and you'll not see inflammatory polyp. Even if it occurs, it will not have so much dilated gland. Lamina propria expansion will not be so much, and there are no any fungal elements in the slide provided. Inflammatory polyp, yes, we can consider an inflammatory polyp. So in inflammatory polyp, what happens is, mostly we'll see this first picture is of an inflammatory polyp. There will be granulation tissue, but there will be no much crypt dilatation. That Swiss cheese appearance will not be there. And always in an inflammatory polyp, there will be some history of inflammatory bowel disease or any infection occurring. Solitary inflammatory polyp occurring is very rare. Another differential diagnosis, mucosal prolapse polyp. This usually occur in the region of the rectum. So what you can see here is, here crypts are distorted. So here, this is the lamina propria. What happens here is there will be muscularization of the lamina propria. Here you can see the smooth muscles in the lamina propria, and there is splaying of the muscle fibers. These things will not be seen in your juvenile polyps. And mucosal prolapse polyp is diagnosed based on the mucosal splaying, and you can see cryptitis, cryptapsis, and gland distortion can be present in these cases. And another DD which you can consider is a hypoplastic polyp. Similar here, the mucosa will be intact, and there will be hyperplasia and serrated epithelium can be seen. And there will be back-to-back arrangement of the glands, and there is no cystically dilated glands, and the lamina propria will not be dilated in this case. So this is a case discussion. Thank you.
Thank you. With that, we come to the end of this slide seminar session. I leave the final comments to Dr. Suneet ma'am and Umashan professor if they are around.
1 minute, sir.
Yes.
Hello.
Yes.
Yeah, so I'd really like to thank KCIAPM for giving this opportunity to showcase our cases, and we thoroughly enjoyed the event. And the PGs were very proactive, and they did an excellent job. And I congratulate everybody who could do all these slides and came up to some diagnosis, because ultimately it's all a learning process, and even till now our learning has never stopped. So congratulations to everyone, and thank you so much from Agilus Diagnostics, Bangalore. Hello, Aditya. Hello. Hello, am I audible?
Thank you.
Hello.
Yes, ma'am. Thank you, ma'am.
Okay then. Thanks, Aditya.
All right.
Thanks a lot.
To the PGs, I would like to tell that we will be issuing the certificates for this particular session in a day from now. And they will join us for CAPCON 2025. Thanks a lot for joining us.
Thank you.